Good morning, and welcome to the 18th Annual Cancer Summit, brought to you by the Partnership to Reduce Cancer in Rhode Island. I'm Jim Wilsey, and I'll be your facilitator for the summit today. Now, at our very first planning session in January, the observation was made that people tended to wander in and get situated during my welcoming remarks. With that in mind, I realized that one of my jobs is to warm up your listening skills so that you don't miss anything in our important sessions. So let me try to do that. And with all respect to our pharmaceutical companies who are out there, who, if you're not a professional, don't go out there. I'll try using their ad techniques. Their ad techniques go something like this. Warning, listening and engaging to this summit may have advantageous side effects, which can cause excitement, insight, increased psychic energy, cooperation with peers, better understanding about the role of diet and exercise for improving cancer resilience, and a general sense of hopefulness for treatment outcomes. Now, if you experience any of these symptoms, tell your doctor and anybody else who might gain from listening to this summit, which will be out on our website on Basecamp in just a couple of weeks. So if you know somebody who could benefit from the summit, especially your doctors, because they need to know about diet, exercise, and all of the interdisciplinary skills that are necessary for patients. Now, I don't want to say that I've been at this for a long time, but I can remember when the phone charging stations that are just out there, that are in front of the restrooms, were pay phones. Now, if you don't know what a pay phone is, and maybe you don't if you're under 30, that was a phone that was on the wall with a little slot and you put money in it. Money, I say money, coins. I don't think we even use coins today, but we used to put coins in, and then you could talk to people for about 3 minutes. But they were there. Now, one of my roles is to ask you to turn off your phone or put it on silence or vibrate. Now, does anybody really ever turn off their phone when I say that? No, nobody turns off their phone. And we're so addicted to them that they're causing a new disease. And it's not brain cancer. That was disproven in research, and that's been settled. So I'm talking about FOMA. Anybody know what FOMA is? FOMA is my acronym, fear of missing out. Okay. Now, you may struggle with it. You know that your phone is on vibrate, a text comes in and you see it move, and who knows who it is, you know? Then you look down, and before you look down, you say, well, everybody at work knows I'm here, but maybe there's such a difficult situation that I am the only one in the world that can handle it. So I better check my phone. Then you check it and you see that it's a friend. At that point, you know, you look and you have to find out what's on that text because it's so important, right? And on it goes all day because who knows, it really could be something important. Maybe your friends are going to the Roger Williams Jack-o'-lantern event tonight, and you don't want to miss that. So it was a good thing you picked up your phone and found that out at 8 a.m. in the morning for tonight at 5 p.m. So you can plan for that. But you don't want to miss out on things. So we got that fear of missing out that goes on nowadays. Now let me draw your attention to the screens, and they will be running If you have signed up and are going to get continuing education and you read those screens will let you know how to do that. And if you don't get it by the end of the session, I'll go over it again toward the end so that make sure that those people who have signed up and paid for continuing education are able to get that. So, as I said, I've been at this a long time, and I can remember that there was a time during cancer treatment that if you had nausea and vomiting because of a medication, they had a drug that was called Compazine. It doesn't even exist by that name anymore. And that was the medication you got to take for your nausea. And when it didn't work, and I say when it didn't work, not if it didn't work, because I don't know many people for whom it worked, you were in big trouble. And your doctor would simply tell you, we're treating you for cancer. It's going to be rough, but you're just going to have to take it, live and bear it, and someday you'll be able to eat again. Right? That was the way it was handled. Fortunately, when my wife had cancer in 1993, a new drug had just came out on Dancitron. We know it as Zofran today. And that was the first of the antiemetics that could really work. And it was truly a blessing. And we've come a long way from that time. Nowadays, we recognize that nausea, that eating, good nutrition, good health, exercise are as important for the treatment and the benefit and the resilience of cancer patients as any of the mainstream treatments. Today will be a day to see what the experts in these fields, once called in the 90s complementary therapies, now they're integrative therapies. Now they're a deep, important part and a foundation of what we do for people with cancer and for their families that try to improve outcomes and quality of life. Lastly, this is important for one person in our audience, and you don't have to stand up when I mention it. Just quietly sneak out. But there's a white SUV with Connecticut license plates. Your hatch is open. We didn't close it just in case your keys were in it. We didn't want to lock you out of your car, especially since you're going back to Connecticut. Now, our next welcoming remarks come to us from Pat Stout. Pat is the current co-chair of the board for the partnership. She has been with the partnership for many years and on the board for almost as many. She is a professor emerita for URI, where she taught our next generation of nurses how to be a nurse, using academic knowledge with compassionate care. Pat, thank you for your service, and welcome, Dr. Stout.
Thank you very much, Jim. I want to welcome everybody this morning to the Partnership to Reduce Cancer in Rhode Island 18th Annual Summit. Our program today is designed to be practically relevant, ensuring that every participant can leave with valuable insights and takeaways. Moreover, I would like to express my gratitude to all the organizers, the sponsors, the presenters, the volunteers who have worked tirelessly to make this summit a reality. Your dedication and commitment here laid the foundation for this gathering. I also want to thank everybody for being here this morning and I wish everybody an enlightening and enjoyable summit. And with that, I would now like to introduce our Executive Director, Megan Daniel.
Good morning, everyone. It's a pleasure to welcome you all to the Partnership's annual Cancer Summit this year. As Executive Director, I've had the immense privilege of witnessing firsthand what we can achieve when we unite around our shared mission. This past year, the energy and dedication of our members have translated into truly remarkable achievements. I want to take a moment to celebrate these successes with you all. This year, our lung cancer screening task force planned and hosted a highly successful educational roundtable, driving essential conversations around smoking cessation and the importance of screening. The discussion included evidence-based recommendations for increasing screening rates and improving lung health outcomes across the state. With regards to skin cancer screening, our Skin Check team screened 290 individuals across 5 events. To reach higher risk populations, we were especially proud to screen 59 firefighters at a dedicated event for first responders, broadening our impact where it's needed most. Meanwhile, our Oral Health Task Force continued its support for patients undergoing treatment. With the help of local volunteers, our team assembled and distributed 425 oral health care kits to patients at 5 treatment centers across Rhode Island and southeastern Connecticut. Through a new partnership with Mathewson Street Church in Providence, we hosted our first oral cancer screening event for the unhoused, screening 30 individuals right where the need is greatest. We were proud to partner once again with the YWCA of Rhode Island, whose dedicated team recruited and referred 143 individuals to the breast and cervical cancer screening program, ensuring crucial access to screening, diagnosis, and treatment referral services for those who are under or uninsured. One of our visionary board members created the Cancer Talks, an educational support program where cancer patients, survivors, and caregivers can learn, connect, and share experiences. And I just want to add a quick thank you to those who participate in Cancer Talks and are here today. We've been hosting monthly sessions in Charlestown and are excited to be working on expanding this vital program to 2 additional towns with an express need. Building on national best practices, we put together a specialized team to plan and implement a major training initiative for patient navigators and community health workers called The Role of Navigation in Cancer Care. Using the Project ECHO framework, this comprehensive series connected with over 100 registrants from 22 states. And finally, thanks to the tireless work of our coalition coordinator, Sarah Murphy, who I don't believe is in here, but you'll see her today, we hosted 3 insightful community meetings this year, bringing our members together for engaging, expert-led conversations. If you want to dive deeper into these accomplishments, you can read our 2025 Impact Report, which is available on our website and by scanning the QR code that's on the screen here. And as a reminder, our website is prcri.org. Lastly, if you are not yet a member of the partnership, I strongly encourage you to join. By sharing your experiences, offering your time or talent, or actively engaging in advocacy initiatives, you can play a vital role in helping create a cancer-free Rhode Island. The success of the partnership is a direct reflection of your commitment. Thank you, and enjoy today's presentations.
Thank you, Pat and Megan. Our next speaker is offering greetings from the Rhode Island Department of Health. Dr. Jerome Larkin is that director. You can see Dr. Larkin's excellent credentials his board certifications. Most importantly, he knows Rhode Island and its needs. He's been in the trenches during doing infectious disease consultations during COVID-19's worst days. One of his first days as the director, he stepped into a meeting of the Palliative Care Advisory Council, and his openness and concerns were amazing. The partnership works closely with the Department of Health, aiding to implement the state's cancer and control programs. So it's my pleasure to be able to introduce the Director of the Department of Health, Dr. Jerome Larkin.
Okay, first rule is to not drop the talking points before you, as you're walking up to the stage. Thank you, James, for that kind introduction. And thank you all for being here this morning. I'm glad you made it. Thank you for your patience while we demo the bridge, the old bridge. So on behalf of the Rhode Island Department of Health, I want to thank the Partnership to Reduce Cancer in Rhode Island. This is really phenomenal work that you've all done and are doing to make this summit happen, and year-round as well. The Department of Health's comprehensive cancer control program and oral health program really benefit immensely from your expertise. And we have now reached several cancer milestones. We now lead the nation in lung cancer screening. You can clap. This is, all right, you're listening, taking your cues. All right, this is due in part to the work of the Rhode Island Lung Cancer Screening Task Force, who are a group of dedicated physicians, patient advocates, and public health officials. And nationally, we've also made a lot of progress. We've made many advances in the prevention and treatment. For example, advances in how treatment can be more effective and more easily tolerated. However, there is a lot more work to be done, and that's why we're here this morning. So cancer is still a leading cause of death in Rhode Island and across the country. And today we'll hear from a wide range of experts on cancer survivorship. And I hope you take a lot from this day and keep the momentum going. So these are uncertain times in public health. There's a lot that's politicized. And the thing that we need to keep in mind is that while we do not see ourselves as being political, we might be politicized, and we need to maintain our work and our integrity and just refuse that moniker and just keep on doing the work that we're doing. And I believe that's what we will continue to do at the Department of Health as well. So all of you are testaments to the power and importance of public health and how public health can and does save lives. So thank you all for all you do, and your example is more important now than it has ever been. Thank you.
And now for our first presentation. This is the cancer report for the state, and it's going to be done by Victoria Frew. Victoria presented last year and gave what I thought was pretty informative stuff about what is going on in the state of Rhode Island, where we stand with all the different cancers, and highlighted some great ones. So I'm looking forward to another very informative presentation. Victoria is the Rhode Island Cancer Registry Program Manager. So I don't know how long she's done that, but I know she's presented at least once last year, and I think she was doing that before this. So without any further ado, let me present Victoria to give us the facts about what's going on in Rhode Island.
So thank you for inviting me to be here today. As mentioned, my name is Victoria Frew, and I appreciate being able to start out that Cancer Summit and really set the stage for looking at cancer rates across the state. and to be able to give you sort of that brief glimpse and summary, and overview of where we are with cancer rates in the state, looking both overall and by certain cancer types. As mentioned, I work at the Department of Health within the Cancer Registry Program, and I oversee that program and can give you some background on that. And I'll be walking you through, as mentioned, an overview of the statistics and sort of a report of where we are within the state. So starting out with some quick cancer facts for Rhode Island. On average, there are 6,300 new cancer cases per year, and this number is based on the 2022 data, but on average, that's where we fall, with around 2,200 cancer deaths per year as well. Here I can highlight the Cancer Facts and Figures report document, which is an American Cancer Society document, which really gives a great overview of cancer statistics by state, as well as looking at comparisons between states and thinking about specific cancer cases. We at the Cancer Registry are able to collect data on cancer diagnoses with verified data since the 1990s, and we're able to look at that data every year to be able to report back and have surveillance data so that we can see trends within the state and how that might change depending on geography or demographics across the state, looking at specific communities as well. We're able to collect data through these partnerships with hospitals as well as clinics and labs, understanding more about cancer diagnosis within the state through these important partnerships. And we do this work to be able to understand cancer screening, both in the moment and over time. And as I mentioned, it's really important for us to understand cancer rates and trends across communities to really get a sense of where education or screening efforts might be more effective and how we can benefit individual communities as well as the state overall for a more healthy population. So I'm going to jump right into some cancer facts and statistics and be showing you a few figures. And so first of all, we can think about cancer rates over time and how they've changed within the state. So here we're seeing annual rates of new cancers from the year 1999 through 2022 for Rhode Island. On the x-axis at the bottom, you can see individual years, and rate per 100,000 individuals is on the y-axis there. And for all rates that we report on, they're all age adjusted. Oh, sorry. I'll remember to use this more. So they're all age adjusted, which is how it's important to report cancer data in order to standardize across populations and to be able to compare across populations as well. Here we can see for the years starting in 1999, we had an age-adjusted rate of new cancers was 540 per 100,000 individuals, which was around 6,100 new cases. And you can see sort of this progression over time with decreasing rates when we look at the more recent data. From 2019, the age-adjusted rate of new cancer cases was 488 per 100,000 individuals, and you can see that 2022 time period is 426 new cases of cancer per 100,000 individuals. So we can see the shift decreasing over time. I do want to note, and it might come up in later presentations today as well, that COVID disruptions in the healthcare service related to COVID-19 and the pandemic did see some underreporting of cancer cases within the 2020-2021 time periods, but many cancer types are back to their original reporting numbers. And as we move forward over time, we'll see sort of those rates return to what we would expect. But again, despite that, even through the 2019 time period, we're seeing this decrease over time with incidence. Next, we can look sort of at a more of an overview of cancer rates across the country and see these rates by state. Here we're looking at a map that's evaluating incidence across the US. The map is demonstrating rates using a chloropleth map style, where color coding to represent the geographic distribution of cancer incidence. At the bottom, you can see the key of rate per 100,000 people. The lightest color on the left is 344 new cases to 430 new cases per 100,000 individuals, again standardized, all the way to that darkest color on the right, which is 472 to 518 new cases per 100,000 individuals. And we can see Rhode Island, very tiny on this map, it has an age-adjusted rate of new cancer cases that was 452 per 100,000 individuals. So we fall really into that second to the left color palette of second to lightest color. And we rank about 24th on this. So thinking about comparing state rates across the country, and this is for a 5-year time period, falling somewhere in the middle there. So it's important to think about our state in itself, but also how that compares to other states. We can also think about not only cancers overall within our state, but specific cancer types and how those types have changed and sites rates have changed over time. So here I'm showing the top 10 cancers by site. We can see that top band, this is for a 5-year time period as well, and it includes all race ethnicities as well as male and females. The highest incidence rate cancer, as you can see, is breast cancer. That's among females with a rate of 139.1 new cases per 100,000 individuals. Then from there, prostate cancer has the next highest incidence within the state of 113 new cases per 100,000 individuals, followed by lung and bronchus at 60 new cases per 100,000 individuals, colorectal cancer, uterine cancer, urinary bladder, melanomas, non-Hodgkin's lymphoma, kidney and renal pelvis, and thyroid cancer. So you can see how that sort of trends over the different types of cancer types and seeing which ones have the highest incidence and how those rates compare. We can then look at that, so that was for both males and females, again, of all ages. We can then look at that by males compared to females as well, to see sort of how those trends differ by sex. So again, prostate cancer has the highest incidence rate there of 113 new cases per 100,000 individuals among men on the top panel. Lung and bronchus cancer is the next, at 65 new cases per 100,000 individuals. Urinary bladder and colon and rectum cancer are the next two there. For rates among females, we see that breast cancer has the highest incidence rate, again, of 139 per 100,000 individuals. Lung and bronchus cancer and colorectal rectum cancer are then next in terms of highest incidence among women in the state. You'll notice that the rates among men for lung and bronchus cancer are slightly higher at 65 new cases per 100,000 individuals than among women, which is 57 new cases per 100,000 individuals within this time frame. Colon and rectum cancer also has a higher rate within men of 36 new cases per 100,000 individuals versus 28 among females. It's also important to note that some cancers, such as thyroid cancer, have a higher rate among females and are included in sort of that top 10 category. And thinking another difference between rates among men and women that we see here too is that urinary bladder among men has a rate of 40.1 8.5 new cases per 100,000 individuals, higher incidence rates among males for urinary bladder cancer, when among women, that's around 11 new cases per 100,000 individuals. So seeing the difference there, these differences are similar to what we have seen within the US, and so we can just compare some of these differences that do occur by sex. We can then take a look at sort of how these rates and most highest incidence cancers change over time. So on the left, we can see this 5-year time period, which is often how cancer cases are reported in 5 or 10-year increments on the left. So we see 1995 to 1999, this earlier time period. Compared to, on the right panel, you see the 2017 to 2021 time period. This is among women, and we can see sort of some of these changes that have occurred over time. Similarities over time include that breast cancer rates are the highest incidence rates between these two time periods, followed by lung and bronchus, and colon rectum is third and fourth within those two time periods. So those are some similarities. Some differences among women across these two time periods include that ovarian cancer incidence has actually dropped over time. So we see that further down in the list on the right, the 2017 to 2021 time period. Thyroid cancer has also, on the converse, has increased over time in incidence. So we can see that change from the 1995 to 1999 time period and going up, increasing the 2017 to 2021 time period. Another note that is worth highlighting and important to highlight here is that within that earlier time period, cervical cancer was on the top 15 cancers by rate of highest incidence, and has since dropped off the list, and that the cancer incidence rate for cervical cancer has decreased over time. So we don't see that on this list for 2017 to 2021, so decreasing over time. We can also compare that when we're looking at males. So this is the same structure of having two time periods and comparing cancer rates by time period within those areas and by site. So for prostate cancer, we see prostate cancer, lung cancer, and colon and rectum cancer being the top 3 cancers between both time periods. But we, for prostate cancer specifically, see a decrease in rate over these time periods, which is important to note. In the 1995 to 1999 time period, and this is over 40-year-olds, so looking at sort of those more likely to have a cancer diagnosis, we can see the rate for prostate cancer being 398 new cases per 100,000 individuals. When we compare to the 2017 to 2021 time period, that's 264 new cases per 100,000 individuals. So we can see that shift in lower rates in the more recent time period. We also have some specific changes in rates over time within different cancer types. So stomach cancer has changed and decreased somewhat in terms of incidence, and incidence has gone down over time. And when we compare to the 2017 to 2021 time period, cancers like liver and bile duct have increased slightly in incidence, so just pointing out some of those shifts over time. And then cancers such as larynx, cancer of the larynx, and brain and other nervous system cancers have actually gone down in incidence over time. So we saw those at higher incidence in the earlier time period, but then we don't see those as high incidence and have decreased over time within the 2017 to 2021 time period. So those are sort of some of the shifts that we've seen over time overall and based on male and female cancer rates. Next, I'm going to share, instead of looking at those 5-year time periods, we can actually get a visual of how those rates have changed over time. And we can see on the x-axis, we have these cancer the years of cancer diagnosis. On the y-axis, we have the rate per 100,000 individuals. Each of these cancer types are color-coded. You can see that at the top and on the bottom with their color bands. And we can see that the incidence rate of cancers like prostate cancer, which I mentioned previously, is that top line, that orange, yellowy line. Colorectal cancer, which is the light blue line towards the bottom, and lung cancer, which is the dark green line, have really decreased between 1995 and the 2019 time period. So you can see sort of these trends over time based on these types of visuals as well. You can see sort of, again, the prostate cancer rates, as I mentioned before, from 300, and this is among individuals 40 years and older, again, more likely to be diagnosed with cancer, which went from 380 new cases per 100,000 individuals in that 1995 time period to 304 new cases per 100,000 individuals within the most recent data that we have here, which is the 2019 time period. So that also gives you a snapshot, not just of increments in 5-year time periods, but actually looking by year and seeing these trends visually. We can also look at these types of cancer and think about differences by demographics. So here we can see rates of new cancer, again, in 40-year-old individuals and older, again, for a 5-year time period. And we can see rates among non-Hispanic white individuals in blue in the left-hand panel, non-Hispanic black individuals in orange in the middle panel, and Hispanic individuals with the green color code in the right panel. For all of these cancer types and among these demographics, we see that breast, prostate, and lung and bronchus cancer are the cancers that have the highest incidence rates for each of these. Breast, prostate, and lung, again, are the top 3. Breast cancer rates among those women who are 40 years and older are greatest among non-Hispanic white individuals. You can see that with a rate of 311 per 100,000 individuals in this slide. Prostate cancer rates among those that are 40 years and older among men are highest in non-Hispanic black individuals with a rate of 315 new cases per 100,000 individuals. And of those highest incidence cancers, lung and bronchus cancer, colon and rectum cancer are also have higher incidence rates among non-Hispanic white when you're comparing across populations. Again, these are age standardized and standardized across the population size, so you're able to look between and see sort of rates across different groups and populations to be able to understand the likelihood of cancer and also look at surveillance over time. Next, we can move into thinking about cancer mortality and how those rates have changed over time as well. So the dark blue line at the top of the screen, again, this is year at the bottom on the x-axis and rate per 100,000 on the y, very similar to what I just showed you for the incidence rate slide, but this is for mortality rate. And we can see that dark blue line at the top, which is all malignant cancers. And so we can see this decreasing trend over time from the year 1990, based on death records, through the 2019 time period. Again, the color key is at the top, and on the individual boxes, you can see the rates. So within that 1991 time period, there were 218 cancer deaths per 100,000 individuals. That went down to 2019 of 153 new cases of cancer death related to cancer per 100,000 individuals. So really seeing that decrease over time there as well. Lung cancer mortality rates, that dark green line, have also decreased, so you can see that more clearly here. And colon and rectum cancer mortality rates with the orange line have also decreased over time. It's smaller at the bottom, but you can see some of that shift. And when you look specifically at that cancer type, you can see that. I also to mention that. So observations show really that we're making strides in reducing cancer mortality over time, as you can see from that dark blue line at the top. A lot of this progress has been considered to be related to, of course, advancements in treatment, advancements in screening and detection, and increase in education and prevention efforts that are really critical to be able to detect cancer at earlier stages and also to be able to treat over time. With that, I'd also like to sort of share where reporting and publications can be found and where this data can be sourced. So the Cancer Registry at the Department of Health houses this data. And we actually have an interactive website that you can go to look at specific cancer years and types, and to try to be able to evaluate this and look at sort of surveillance over time and how these rates have changed over time if you're interested in looking at a specific cancer type and seeing some of the surveillance data firsthand. We also have data briefs at the Department of Health where we delve into individual cancer types as more closely and in more detailed ways, looking both at rates by male and female, as well as thinking about different staging of cancer by type and understanding and sharing more of that information to try to be able to be helpful for the general public as well as practitioners to be able to have that information readily available, and we update those over time. We also have periodicals and publications. So based on all of this surveillance data, we're able to go into more depth again to be able to share more information and more detailed information about certain information through those periodicals and publications as well. So with that, I would like to thank you for listening today, and I really want to thank the organizers for putting together this wonderful event and for inviting me to be here. Thank you very much.
Thank you, Victoria. Among other things, those statistics can be used for a number of things, among others, to recognize where we need to put our emphasis. You know, what's the screening doing? How effective are things becoming? That data is very important. So it's good to always hear that, Victoria, and let us to see where we're going. Our keynote presentation today is going to be given by Dan Glidden. Dan is the physician's assistant at Dana-Farber Institute's Zakim Center for Integrative Therapies and Healthy Living. Dan began to gravitate toward treating the whole person, but not only did he gravitate toward treating the whole person, he did something about it. And so now he is recognized and leads moderates an oncology tumor board that's focused on integrative therapies. So we're looking forward to listening to Dan. After he speaks, there will be a question and answer period. I'll repeat this once for now. There are 2 microphones in the room. If you have a question, you need to step up to the microphone and ask the question so that we can get it recorded. And don't ask, why don't we do more of this in Rhode Island? Okay? That's not a fair question, because he'll just say, you know, just do it, because that's what he did. So we may be jealous, but I hope more than that, we're inspired to keep pushing for more integrative therapy for the resilience and benefit of our patients and their families. So with that, I present to you Dan Glidden.
Good morning, everyone. It's my distinct privilege and honor to be here as a keynote speaker today, so thank you for the organizers for inviting me. And really, the work that's done by the partnership is truly meaningful and impactful, so thank you all for the work that you do. So my name's Dan Glidden. Thanks again, Jim, for that introduction. So I work at the Leonard P. Zakim Center for Integrative Therapies and Healthy Living at Dana-Farber. And, I've been a PA for 10 years. I graduated from the Northeastern University PA program. I did my undergrad at BU, so it makes it hard to know who to root for in the Bean Pot. And for those of you who don't know what the Bean Pot is, it's a hockey championship between 4 Boston colleges just for bragging rights alone. So go Terriers and go Huskies. So if you had asked me 10 years ago if I could picture myself working in integrative oncology back when I was in school and cramming for all the tests, I would say, what is integrative oncology? Truly, we had very little training in the world of integrative therapies, and it took me some time to learn about this. So I was at Dana-Farber doing work in the genitourinary medical oncology division, treating prostate cancer, bladder cancer, kidney cancer, among others. And it's amazing to be at Dana-Farber and seeing all the advances that are occurring in research and treatments, and they're not paying me to say this, and we're doing a better job. I mean, we can see, the numbers that Victoria had presented at mortality rates going down. And so we're doing a good job at treating cancer, but I saw that there was a person there that needed more care. And I found out about this Zakim Center at Dana-Farber that was providing acupuncture to patients for different purposes, and massage and other healthy living programs. And I would start sending more and more patients to them. Because, if you're a patient, as all of us are in some respect, most of us are, get a little bit tired of another pill for each thing that we talk about to our doctors. So if I can send somebody for acupuncture for their hot flashes, and avoid another medication, then that was something that I'd want to do. And then eventually they opened a position to have a physician assistant and a doctor give integrative medicine consults, and I just felt drawn towards that. And I said, wow, I can do this for my entire career, and I have not looked back since. So thank you again for having me today, and I'm really excited to be able to share some of my experience that I've gained over these years. So, the outline for today, we'll talk about an introduction to integrative oncology. What is it? We'll talk about lifestyle and cancer prevention. We'll do a bit of an introduction to exercise and nutrition, but I know we have some experts in the nutrition and exercise oncology fields today, so I won't go too much into their realms. I don't want to step on their toes. We'll talk about how to manage symptoms with integrative therapies for issues like pain, fatigue, anxiety, depression, and insomnia. We'll talk a bit about supplements, and then lastly, about Zakim Center resources that are available to patients at Dana-Farber, but also to anybody with an internet connection. So, what is integrative medicine? So, integrative medicine is a holistic approach to healthcare that combines conventional Western medicine with complementary therapies. We focus on treating the whole person and not just the symptoms of the disease. And the key principles of integrative medicine are patient-centered care. We really do put the patient at the center and create the treatment plan around them. And it's quite a comprehensive approach, taking into account personal factors, patient values, social economic factors. We rely on evidence-based therapies that have been proven effective by scientific research. And combining treatments is often the case as we see patients that are on chemotherapy or other sorts of cancer-directed therapy and providing treatments on top of what they're already doing in a safe manner. Of course, if we can prevent cancer, that's much easier than treating it, so we do focus a lot on healthy living and cancer prevention in our consults. And of course, we collaborate with our oncologists in the community. Integrative medicine and alternative medicine are sometimes terms that are used interchangeably, but there's some pretty important differences. So integrative medicine, as I had mentioned, is used alongside conventional treatments and is truly complementary, and alternative medicine is often promoted to use instead of conventional treatments, which we don't advise. Integrative medicine is evidence-based, based on randomized clinical trials in many cases, and alternative medicine is mostly unsubstantiated claims from preclinical studies, test tube animal studies, or small trials. Integrated medicine is non-invasive, while alternative medicine is often quite invasive. And integrated medicine is also relatively inexpensive, while alternative medicine can sometimes cost thousands of dollars per month, depending on what we're doing. And integrated medicine is focusing on supporting quality of life and side effects and pain management. And then alternative medicine is sometimes touted as curative. So integrative oncology then is a patient-centered, evidence-informed field of comprehensive cancer care that utilizes mind-body practices, natural products, and lifestyle modifications from different treatments or traditions alongside conventional cancer treatments. So that's a bit of a mouthful, but it's a very comprehensive definition of what we do. So the different types of integrative therapies are mind-body therapies, massage, acupuncture, nutrition, and physical activity. And then mind-body therapies, which are therapies that use the mind-body connection to try to elicit a positive change in ourselves. Meditation, hypnosis, guided imagery, progressive muscle relaxation, yoga, qigong, and mindfulness-based interventions are all examples of mind-body therapies. And we'll get into the details about how some of these can be helpful in a few minutes. So again, preventing cancer should always be the objective. If we can prevent it, it's much easier than treating. So how does lifestyle factor in? So we know that around 20% of cancer cases in the United States are directly attributable to lifestyle. So suboptimal diet, diets rich in processed meats, red meats, sugar-sweetened beverages can contribute. Low physical activity, and also excess adiposity or extra fat gain. And we know that if we can improve these conditions, we can potentially reduce cancer rates. And exercise, we found, is associated with a 10 to 20% reduction in incidence of these different cancers, so colon, bladder, breast, esophageal, endometrial, renal, and gastric. If there was a pill we could take that would reduce cancer incidence by 10 to 20%, we would all be lining up around the corner at our doctor's offices to get that. But this is something that we can access just by changing some of our lifestyle. So we look to our friends at the American Cancer Society for recommendations for cancer prevention. They help us understand that, we need to move more and sit less, essentially. So by being physically active and limiting sedentary behavior, we can reduce cancer rates. And so, for adults, it's getting 150 to 300 minutes of aerobic exercise per week. And for kids as well, getting them off the screens and out into the yard is easier said than done, but it's important. And then following a healthy eating pattern, so more fruits and veggies and less junk, essentially. So a diet more rich in fruits and vegetables, whole grains, legumes, limiting red meats and processed meats and added sugar, and limiting or avoiding alcohol, for sure. We know that adults who closely adhere to these guidelines have a 10 to 20% lower risk of cancer diagnosis and a 24 to 30% decreased risk of cancer mortality if there is a diagnosis. These numbers are truly impactful, and again, if we had a pill that could confer this for us, we would all be wanting to take that. At the American Institute for Cancer Research, in their continuous update project of all the observational data that comes out about cancer prevention, they have similar recommendations to the American Cancer Society. So being a healthy weight, being physically active, eating a diet rich in whole grains, fruits, vegetables, and beans, limiting fast and processed foods, limiting red and processed meat, limiting sugar-sweetened beverages, alcohol, and importantly, not relying on supplements for cancer prevention because we really don't have the data to suggest that they're truly helpful. And then after a cancer diagnosis, it's best to follow these recommendations. So that's a relatively easy way to live healthfully, both with and without a cancer diagnosis, is following these guidelines. So we have an exercise prescription for primary and secondary prevention of cancer. Again, that's the 150 minutes to 300 minutes per week of moderate intensity aerobic exercise. Moderate intensity, say I'm walking down the street with Jim and we're having a conversation. If we're walking at a brisk pace, we can have that conversation comfortably, but if we tried to sing a song, then we would get out of breath. And that's how you can picture a moderate intensity aerobic exercise. Not that anybody would want to see me singing while I walk down the street, but it's just one way to conceptualize this. And then twice weekly progressive resistance training can be helpful as well for cancer prevention and also for our bone health, for our physical strength, our functional capacity. About half of us are meeting the aerobic exercise guidelines, and only about 23% are meeting both guidelines. So there's a lot more that we can do within ourselves to help prevent cancer, and for the healthcare providers in the audience, certainly trying to push these recommendations more can be helpful for reducing incidence of cancer. So a very brief introduction to nutrition now. Again, I don't want to step on the toes of my colleagues today. There's been a lot of research done on different types of restrictive diets, intermittent fasting, ketogenic diet, low-carb diets. They've been really hard to study. All these trials are very small, 50 or so patients, 3 to 6 month intervention period, and low adherence rates. Even when we give people, here's your box of food for lunch, here's for dinner, we still have low adherence rates. So it's really hard to hang our hat on any of that data. What we do know is that the Mediterranean diet is one of the more well-studied and well-understood eating patterns, which is a diet rich in fruits and vegetables, legumes, poultry, fish, nuts, seeds, and olive oil. Very similar to some of the cancer prevention guidelines that we talked about, with a low consumption of meat and dairy products. We know that through different randomized control trials and meta-analyses that there are reductions from this diet in weight gain, risk factors for diabetes and cardiovascular disease, overall mortality, cancer incidence and mortality, and also Alzheimer's and Parkinson's disease. And so typically the recommendation is to follow something akin to the Mediterranean diet. And again, we see all these benefits from just an eating pattern, and that's pretty impactful, because if this were a medicine that we could take, we would all be wanting to take that as well. And so this is very basic, and this is what I like to show to people, but this is a way to think about how to eat healthfully. And the Mediterranean diet doesn't have to be olives and feta cheese with every meal. It's more about what the components of your plate are. So half the plate being fruits and vegetables, emphasizing whole grains over refined grains, because there's so much fiber and other good nutrients in the grain that are stripped away when we refine it into a white bread or a white pasta. And then healthy proteins, chicken and fish, but also beans, legumes, nuts, and seeds. Following this dietary pattern can help us live more healthfully, but also give us the grace to take purposeful off-ramps to enjoy life here and there. So enjoy dessert every once in a while, or enjoy a glass of wine every once in a while without feeling guilty about it, which when you follow a more restrictive dietary pattern, there's a lot of guilt when you fall off of that diet. So I encourage you all to give yourself some compassion as you go forward. And a bit of an intro to exercise. So we know that during treatment for cancer, there are true benefits to exercise, which include fatigue, quality of life, physical function, anxiety, depression, and lymphedema. And again, these general exercise guidelines that we have for cancer survivors or people living with a cancer diagnosis are similar to the cancer prevention guidelines. So 150 to 300 minutes per week of that moderate intensity aerobic activity, and twice weekly progressive resistance exercise. Now, this is an initial starting gate prescription for somebody who isn't exercising at all. We work up to that, and we can utilize our exercise oncology colleagues to help get patients to their goals in a safe manner. But it is safe for people with a cancer diagnosis to be exercising. But of course, always talk to your doctor before you engage in any sort of new activities. The American College of Sports Medicine helps us with some data here, and this table shows different exercise prescriptions for different relevant health outcomes. So we know that if we have a patient that is fatigued or has decreased physical function or is having anxiety or depression, we have these, based on empirical data, these exercise prescriptions that should be able to help improve those outcomes. I won't go into each of these, but I think it's very interesting that we have this type of data. So we have a landmark evidence alert. I couldn't program a siren in there, and I guess that's a good thing because nobody would want that anyway. But for the longest time, we had data for exercise that showed us that there was associations with improved survival from cancer, but these were associations. When we have observational data, there can be other healthy person attributes that are contributing. So the people that exercise more are more likely the people that will eat more of a healthy diet, will manage their stress, are sleeping better, are going to all their doctor appointments. So we had associations that exercise was helpful for survivorship, but we didn't have any randomized trial data until now. So we have the challenge trial, which was a randomized control trial for people with high-risk stage 2 or stage 3 colorectal cancer that were randomized after adjuvant chemotherapy, so after surgery and after the chemotherapy that came after surgery, to either get a structured 3-year exercise program or health education. And what they found was that the people that received the exercise intervention had an improved disease-free survival of 6.4% and an improved overall survival of 7.1%. This is really impactful and major data because now for the first time, we have true gold standard level data that shows us for this patient population, exercise improved their survival. And we're really excited by this data because we hope that this is true for other cancers as well. We can't extrapolate to other cancers, but we're hoping that more and more data like this comes out in the future. But great news for our friends and loved ones and patients who do have a history of colorectal cancer and fit into this trial population. Now let's talk about symptom management via integrative therapies. We'll talk about pain first. So ASCO, the American Society for Clinical Oncology, and SIO, the Society for Integrative Oncology, which I'm a part of, create joint guidelines for supportive care. And so I don't know how much of this you can read, but we have different symptom settings of pain. So aromatase inhibitor-related joint pain. Aromatase inhibitors are medications given to women with breast and ovarian cancer in many cases. We have general cancer or musculoskeletal pain, CIPN, which is chemotherapy-induced peripheral neuropathy, procedural and surgical pain, and we have all these different integrative therapies that have enough data to make it into the guidelines. Some of these therapies are more strongly backed by data than others, but all of them really have low to zero side effects. So we see that acupuncture is a top-line recommendation for aromatase inhibitor-related joint pain and also for general cancer or musculoskeletal pain. And for neuropathy, which is a really vexing issue that affects a lot of people that have had chemotherapy, we see acupuncture and then reflexology are also potentially beneficial. So I'll go into some of the data behind some of these guideline recommendations, but it's just wonderful to know that we have options here that aren't another medicine. And not that these may reduce the need completely for medicines for pain, but it's another layer of good care on top of what people are receiving and can potentially reduce the dose of some pain medicines if that's wanted. So this is a trial that looked at acupuncture versus placebo, sham acupuncture, or usual care for aromatase inhibitor musculoskeletal symptoms. That's what AIMSS stands for. And so people received 12 acupuncture sessions over 6 weeks, so 2 per week, and then once a week for an additional 6 weeks. And we can see that the true acupuncture group had a more robust change in their pain score than did the sham or the control group. And these results were durable. So we can see that all the people start at the same mean pain score all the way on the left. And then after the first 6 weeks, each of them had a benefit of some kind, but the true acupuncture group did better. And then when the intervention was stopped at 12 weeks, we see that at 24 weeks, people still had a durable pain relief benefit just from acupuncture. So that's a really interesting data. And in those guidelines, they suggest that acupuncture should be offered to women with aromatase inhibitor-related joint aches. We also have a small study that shows that yoga can be helpful for these joint aches as well. A twice-weekly yoga program for 8 weeks had improved pain, but also balance and flexibility, which is important. And so, this data is from a pilot trial. It's not a robust, very large-scale trial, but yoga itself is a, very low-risk intervention and with potentially great upside. So it's something that is reasonable to suggest to people that are experiencing this type of pain. For chemotherapy-induced peripheral neuropathy, this was also a pilot trial that we were doing a larger follow-up trial on, a phase 3 trial, that showed that people that received real acupuncture, so that's the orange line, had a improved neuropathy pain score than did the sham or the usual care. And just a bit about sham acupuncture. The way that sham acupuncture is done is either needling an area that's not a acupoint, or just tapping a needle tube on somebody's skin to make them feel like they're being needled. And we see that still there is some placebo effect there from the sham acupuncture. And so we're doing what we can to try to reduce that placebo effect. But even though there was some placebo effect here, their pain went back to their baseline essentially, but the real acupuncture group had improvements in pain that also was durable. So at the 8-week end of treatment and the 12-week follow-up, the pain scores were the same. And then, there are plenty of us that are needle phobic and can't imagine the prospect of voluntarily having needles placed all over our body to help us relax or reduce any sort of symptoms. So a trial was done at Memorial Sloan Kettering that compared acupuncture to massage for pain in people living with advanced cancer. And they found that the massage did basically just as well. Each of these treatments were needed frequently, but massage was found to be just as good as acupuncture at reducing general cancer pain. So that is also an option for people if they don't want to receive acupuncture. And finding a good oncology massage therapist is really worthwhile. And there is the Society for Oncology Massage that people can look at, and there's a Find a Practitioner tool where you can find somebody in your area. I don't have that link up here, but just try to remember Society for Oncology Massage. Oh yes, and both of these treatments were associated with pain reduction, but also with improved fatigue, insomnia, and quality of life. So again, if we had a medicine that improved pain, fatigue, insomnia, and quality of life, we would all be lining up for it, and this is with acupuncture or massage. So how about nausea and vomiting? Really, when we think about integrative therapies for nausea and vomiting, we're thinking about acupuncture. And so a 2005 meta-analysis showed that most of these studies favored acupressure over the control. So in this plot, if the dots are over on the left side, that favors acupressure or acupuncture. And so most of the studies we see showed benefit. And then a 2013 systematic review agreed that electroacupuncture was more superior to sham and more superior to usual care for chemotherapy-induced nausea and vomiting. So another potential benefit to acupuncture for treatment-related side effects. And then this plot shows that the electroacupuncture group had a much lower total emesis episodes than the pharmacotherapy group alone. And that goes to Jim's earlier point about compazine being somewhat helpful, but not so much. So we can get some good benefit from combining perhaps antiemetics plus acupuncture. And then what about fatigue? Fatigue is probably the most common side effect that most people with cancer are experiencing. And again, ASCO and the SIO teamed up together to make some fatigue guidelines. And we see that exercise is the top recommended intervention for both during and after active treatment. Then we also see that cognitive behavioral therapy and mindfulness-based interventions are on the guidelines as well. And why is that? It's not that fatigue is in our minds only. No, it's truly a physical manifestation of our disease or our treatment. But if we can find ways to cope with it, that can help lessen the severity. And so, finding a good therapist for cognitive behavioral therapy or a mindfulness-based stress reduction program, MBSR, is something that may be quite helpful for reducing fatigue. And a meta-analysis had looked at exercise versus pharmaceuticals versus psychological care for cancer-related fatigue, and we see that the effect size for the pharmaceutical group was the lowest of all, with exercise being the highest, a much more robust effect size. So just another plug for exercise to help improve our lives. Anxiety and depression rates are pretty common in this space as well. And again, the Society for Integrative Oncology and ASCO created guidelines to help treat anxiety and depression. So we see the top guideline, the top level recommendation for anxiety and depression, both during and post-treatment, is mindfulness-based interventions. And so, a little background on what MBIs are. So these are therapeutic approaches that incorporate mindfulness practices, including yoga and meditation, with the goal to promote mental health and well-being. So these are typically given in a group format with weekly meetings, either in person or virtual, over 6 to 9 weeks, where the daily practice of mindfulness is taught to help with stress management. And so people learn the skills of mindfulness through daily home practice of various forms of meditation, breathing exercises, and gentle movements. And so, at the Zakim Center at Dana-Farber, we offer one of these MBSR courses, or mindfulness-based stress reduction courses, but these are available all over the country. And so if you're not a patient at Dana-Farber, you can certainly find one, hopefully closer to home, by looking at psychologytoday.com. We see that from this systematic review and meta-analysis that meditation can help with so many of these different outcomes. So anxiety, depression, stress, negative affect, positive affect, quality of life. We see that all these studies basically favor meditation, either mindfulness or mantra in one form or another. And so again, if we had a pill that could help with all these things without side effects, we would all be clamoring for that. And then, the next line recommendation is yoga for anxiety and depression. And many of us consider yoga to be, an exercise modality, something to help with recovery or something to help with our balance and flexibility. And truly, that's the case. But yoga can also reduce a lot of different symptoms and improve quality of life for people. So in this study, they found that yoga improved anxiety, stress, depression, quality of life, distress, and also fatigue. And so yoga is a relatively accessible modality for most people. If you don't have a studio that you like to go to, I will share with you our website at the end of the presentation today, where we have free exercise videos for anybody to use. And then how about vasomotor symptoms, or hot flashes? So hot flashes are something that are very common, of course, for women in perimenopause, but also for women treated with ovarian suppression for breast cancer or ovarian cancer, and also for men treated with androgen deprivation therapy for prostate cancer. And for some people, hot flashes aren't too bothersome, but for some people it causes significant distress throughout the day or throughout the night and interfering with sleep. So again, acupuncture comes in as a potential beneficial therapy. So this was a trial that was done for women with breast cancer. Everybody received a booklet on climacteric syndrome, and then there was also acupuncture that was given to one group. So the blue line, the dotted line, is the enhanced self-care group that got the booklet on climacteric syndrome, that had a little bit of a reduction in their hot flash score, but the acupuncture group had a much more robust benefit from the acupuncture in terms of their hot flashes. And again, like in the other studies that I had showed you, the end of treatment occurs, but then at the 3 and 6 month follow-up visit, the benefits were durable and still having reduced hot flash scores. So that's truly wonderful, because there are medications to help treat hot flashes, but they are usually coming with other side effects. And so here we go with another integrative therapy to potentially be impactful. And also we saw similar benefits in men with prostate cancer. Of course, this is a smaller study, to only 22 people, but 55% of the participants had at least a 50% hot flash reduction. So that's significant data. And then insomnia, because if we're not sleeping well, how can we feel well during the day and complete all of our daily tasks, be good family members and society members? So cognitive behavioral therapy is truly the gold standard for non-medicinal treatment of insomnia. This is usually delivered by a psychologist or another healthcare provider over weekly visits, focusing on sleep hygiene and stimuli avoidance, and also different behavioral techniques to improve sleep efficacy. It's a really great treatment option, but it does require all these multiple visits. They did a study that looked at acupuncture versus CBTI for insomnia, and they found that the blue line is CBTI, the orange line is acupuncture. The CBTI surely did a better job, but acupuncture also helped reduce the insomnia severity index for these people. And again, that treatment benefit was durable after the intervention was ended for each group. And we look a little bit deeper into that data, and we find that for mild insomnia, CBTI was truly the winner, so on the bars on the left. But for more moderate to severe insomnia, we see that acupuncture actually had a better effect than it did for mild insomnia. So food for thought there. Tai Chi has also been compared to CBTI, so Tai Chi being a very slow, purposeful martial art that's quite meditative. Regular practice of Tai Chi compared to CBTI, they found it was non-inferior, so not any better, but not worse. And so this is another potential intervention that we can use with people who also want to move more and help relax, Tai Chi instead of going to CBTI. And again, we see that yoga can be helpful for improving sleep quality. It wasn't compared to CBTI as other interventions were, but we can see in this plot here, the blue lines are yoga, with the further they are to the right, the more improvement from baseline. And we see that for almost every category here, for sleep quality, latency, efficacy, duration, yoga did provide a benefit over the control group. So that's it for the symptom management portion. There is certainly more that we can do, but I want to give you the highlights. I want to talk a bit about supplements because these are quite commonly used, and we see them a lot in our clinic. So currently, we know that around 64 to 81% of people with a cancer diagnosis are using supplements in one form or another. And to optimize their health or complement to cancer treatments or assist in a healthy diet. And it can feel really empowering to take some control back because we are all driven by our autonomy or our ability to make choices for ourselves. And when we have a cancer diagnosis, that is a perfect example of our autonomy being taken away from us. So any reasonable person would want to do whatever they could to grab that steering wheel and take control back. And for many of us, supplements is one way that we help contribute to our own care. All that being said, those supplements are not currently recommended to prevent cancer or to augment cancer treatments because there are some risks and not very sound data for many of them. And if we go back to our American Institute of Cancer Research recommendations, they do suggest to not rely on supplements for cancer prevention. Looking at our guidelines from the American Cancer Society, they help us understand that we should try to attain all of our nutrients through dietary sources alone before considering supplements. But if there are, nutrient deficiencies, either biochemically, like a low vitamin D or B12, or clinically, we have a bone density scan that shows low bone density, sure, that's an indication for calcium and vitamin D supplementation. Or if nutrient intake is persistently below 2/3 of the recommended intake level. And our dietitian colleagues can help us determine if that's the case or not. So those are some areas where we find that we can safely prescribe some supplements, and otherwise it's a little bit more of a gray area. Now, I'll talk about the potential for harm, but most supplements are benign. I don't mean to demonize the whole industry, but we need to treat supplements as a medication and make sure that we tell our doctors if we're taking them, or doctors ask your patients about them, so we can ensure that there are no interactions. So supplements are not regulated by the FDA, so there's no approval process needed before something can be put on the market, and we don't always know if what the quality is, what's on the label versus what's actually in the capsule or the tablet. We have third-party sources that can review supplements for us, but this isn't required prior to them being put on the shelves at your local store. There can be quality issues, contamination, or even adulteration with other pharmaceuticals. A classic example of this is men's health supplements that were found to contain Viagra, so it's no wonder that they were so effective. There is the potential for supplement drug interactions, and this is important if we're on a chemotherapy or a cancer-directed therapy, because if we're interfering with the metabolism of that treatment, we could either slow the metabolism down and increase the chemotherapy level in the blood, thus increasing toxicities, or if we move it too fast, if we speed up the metabolism, that could potentially decrease the efficacy. So both of these are important considerations. And really, just more research is needed. It's not that there isn't a place for supplements in our world, but we just need more high-quality research. So most of supplements claims rely on preclinical data, meaning test tube and animal studies. And we don't always know if these results translate to benefits in humans. We need to have human trials to really understand what happens in our complex physiology. But when that promising preclinical data is found, it should lead to larger scale clinical trials. And a great example of this is Taxol chemotherapy, or paclitaxel is the generic name. Now, back in 1964, it was discovered that extract from the bark of the Pacific yew tree was toxic to a certain oral cancer cell in a test tube, which was promising. And so then a few years later, the chemical structure of Taxol was isolated and published. They had to make a synthetic form because they found that it would take 60 pounds of the tree bark to make 1 dose of the medication. So they had to make a synthetic version. Then finally, in 1977, animal studies confirmed the anti-tumor activity. In the 80s, large-scale human clinical trials were conducted. And finally, in 1992, the FDA approved Taxol for refractory ovarian cancer. And now it's one of the more commonly used chemotherapies for ovarian and also breast cancer. So this is a great example of how natural products can make their way into our cancer treatment armamentarium, but really we need robust clinical research to get them ready for prime time. A great website and a great resource for you all is the About Herbs website from Memorial Sloan Cancer Center in New York. This is a website and a free phone app that has a patient-facing component and a clinician-facing component. It says 290, but there's more than 300 different herbs or supplements that are categorized here with their clinical summary, all the data behind why they're used, what studies have been done on them, what the warnings could be, what the drug interactions are, lab interactions. And it's a great way to get some good scientific data if you're considering a supplement or if you're counseling patients on supplements. So I have the website down there at the bottom, but if you just Google Memorial Sloan Kettering About Herbs, it should come up, or in your app store on your phone. So the bottom line for supplements is we really need to use them with caution. Many are benign, but we need to treat them like a drug when we're taking them with other medications. If you can achieve all your nutritional needs through diet alone, and certainly speak with your oncologist or your doctor if you're currently using supplements or planning any. An oncologist, ask your patients about supplements, because studies have shown that many times people won't divulge what they're taking because they're not asked. So just simply asking can lead to more conversation and building more trust, frankly. Now, finally, what can we do for you at the Zakim Center? Now, for people that are patients at Dana-Farber, you're eligible for all of our resources, which I'll go over, but there are plenty of resources that are free for anybody with an internet connection, and I'll go over those today. So the Zakim Center provides patient-centered integrated medicine services and programs that are evidence-informed and support patient well-being before, during, and after cancer treatment. So we have on-site acupuncture and massage. That was the closest icon I could find to massage. I think it's actually somebody giving CPR, but we don't, unless we have to, we don't do that at the Zakim Center. We offer nutrition education, yoga and exercise classes, expressive arts therapies, meditation sessions, and one of those mindfulness-based stress reduction courses, and then integrative medicine consults, which is what I do. So if anybody has a Dana-Farber medical record number, even if you don't get treatment there, but you have seen an oncologist there for an opinion consult, you're eligible for all the on-site services, a consult with myself or my attending. But what can you do if you're not affiliated with Dana-Farber? That's what I'll go over now. So we have, this is just a list of all the different programs we have, all the types of exercise that is offered, the expressive arts therapies, we have nutrition education, and the meditation courses. And this is all through the MyZACM website. So for the next couple of slides, I'll have the website at the bottom of the screen and also a QR code that you can scan. Feel free to take out your phones and turn them back on if you listened to Jim's advice before. So we do have music therapy resources. Our music therapist moved to California, which I understand, but we still have all her archived music-guided breathing exercises, which can be really helpful to find some calm during the day. So these are available for free to anybody. All of our exercise resources. Now, if you wanted to sign up for a class and take a class with an instructor, you would need to be a Dana-Farber patient, but we have all these on-demand videos that are pre-recorded, ready to go for you whenever you'd like them. So for aerobics, for strength training, yoga, chair classes, dance, and Tai Chi, these are all available to you. And then we have these curated video collections as well. So we have workouts just to help manage lymphedema. These are usually yoga protocols. We have videos just to help manage neuropathy. Again, these are yoga protocols. Breakdowns of different poses. So if you've never done a split squat before, they will have a video that shows you how to do that. And then we have these Move in Minutes videos, which are all 20 minutes or less for those of us who are short on time. We have meditation classes that we offer, so either mindfulness meditations or sound bath. If you've never experienced a sound bath before, I suggest that you try one. It's a truly, transcendent experience. And so these are available for free as well. On our nutrition page, if you are a Dana-Farber patient, you can take the nutrition courses, which are over Zoom. But otherwise, we have all these on-demand resources as well. So we have recipes for, if there's diarrhea or constipation, or if there's mouth sores or taste changes. This is just another example of some of these recipes that we have. We also have a What to Eat When video series that one of our dietitians made with practical tips on what to eat when blank. You have taste changes, you have diarrhea, you have nausea, weight changes. And then we have a page of nutrition questions and answers. So videos and presentations about, different things like sugar increasing cancer risk, things like that. So, in summary, first, thanks you all for your attention. That was a lot, I know. So in summary, integrative oncology is a patient-centered, evidence-informed field of comprehensive cancer care that utilizes complementary therapies alongside conventional cancer treatments. Lifestyle is really key for cancer prevention. We know that 20% or so of cancer cases are directly attributable to lifestyle. So follow the American Institute for Cancer Research or American Cancer Society prevention guidelines to help prevent cancer and also to live healthfully if you do have a cancer diagnosis. We have during treatment benefits from exercise in terms of fatigue, quality of life, physical function, anxiety, depression, lymphedema, and the American College of Sports Medicine has prescriptions for each one of these outcomes. So again, we have no convincing evidence that rigid restrictive diets are helpful for prevention or for during treatment or survivorship. And so essentially following that Mediterranean diet can be a healthful and easy approach to nutrition. We learned that the challenge trial showed an absolute survival benefit for people with colorectal cancer. So we're hoping to find more data that supports exercise for treatment outcomes in the coming years. And I hope you learned that there are many benefits of integrative therapies during and after cancer treatments for pain, fatigue, hot flashes, anxiety, depression, insomnia, and more. Thank you again for your attention. I'm happy to take any questions, and thanks again for the organizers for allowing me to present today. Thank you.
Thank you, Dan, for a very informative presentation. Reminder, if you have a question for Dan. There are 2 microphones, so please go to the microphone and ask the question into the mic, and then Dan will answer.
Thank you.
Hi, Dan. Thank you. It was a great talk. My question is more on the sort of administrative side. I'm interested in hearing a little bit about the idea of the Integrative Care Tumor Board and how you engaged the entire oncology team to get these great services to the patients.
Yeah, so thank you. Yeah, so the question was about the Integrative Oncology Tumor Board. So each second Tuesday of the month, I'll moderate a tumor board, which I came from last night. It ended at 6, and I had to hightail it down here. Usually this is within our own departments, different practitioners, either myself or the acupuncturist or massage therapist will bring patient cases to us. To discuss, this is a potentially difficult case, or this is something interesting about them, what can we do to benefit them? So that's really what the tumor board is for. It's to facilitate discussion between our colleagues, and also to help determine, a care plan for each patient. And there are times that we also will pull the oncologist into that discussion as well, and sometimes they're interested in that. And so I hope that answers the question, yeah.
Hola, buenas. I'm sorry. I take alternative medicine when I was diagnosed with cancer, and I did through Spanish-speaker doctors online. I was with those doctors. The doctors recommend many of the recommendations that you already did, and I pay from my pocket. My question here is, how are we going to use this treatment if the insurance is not covering those kind of treatment?
Good question.
And I certify those treatments help me a lot with my process.
And are you referring to like acupuncture and massage, those type of treatments?
I did different stuff, like changed my diet, exercise, and also I took supplements, and other recommendation was vitamin C infusions, I don't know if you heard about it.
Yeah.
And ozonotherapy too.
What was the last one?
Ozone therapy, ozone.
Okay, got it,
Yeah.
Yeah, so it can be difficult, the financial aspect of some of this. And so, at least for acupuncture and massage at the Zakim Center, we do provide, a patient assistance fund, about 10 free sessions if you meet a certain income threshold. But that can be a limiting factor for a lot of people. And so we want to expand more free services to patients because, even if you use all the free sessions and then it starts, incurring a cost, that can add to financial toxicity for sure. Thinking about supplements and infusions, that's certainly, one of the issues with the more alternative or emerging therapies, because they're typically not covered by insurance because we don't have the robust data to help us to get the insurance companies to cover them. And we're hoping that through more trials that we'll get there, certainly for things like IV vitamin C, because there's so much interest in that. And we're starting to get some small trials that show some benefit for different cancers, but we need that robust research, and then hopefully that becomes more standard of care, and therefore would be less out of pocket for our patients. I hope that answers your question, yeah.
Hello, I have a little congestion, so please excuse me. So my question is, with regard to the data on cancer reduction as it relates to nutrition, were these data based on self-report measures, which we know are kind of inherently biased? And the same thing for exercise, how was it monitored and measured?
Yeah, good question. With nutrition interventions, it's really hard to study in terms of a randomized control trial. So usually these are observational trials, either retrospective or prospective. And so it is many times people reporting what they are doing, and which certainly some reporting bias can come into the data in those cases. And so it's not, it's not the gold standard data that we would want from a randomized control trial, but it is more of an associating type of data. And with exercise, there have been some randomized control trials that look at treatment side effects and quality of life. And then, like I said, recently we have this, challenge trial that showed the true treatment benefit or survival benefit for people on an exercise oncology program after colorectal cancer treatment. And so there's a whole consortium of that's looking at treatment-related outcomes. How does exercise influence how much chemotherapy people can receive? Do we receive all of our doses? And so those randomized control trials are coming. But for the majority of nutrition research, it's observational.
Hi, my name is Kate. I'm a cancer survivor, most importantly, but I'm also a dietitian and a yoga teacher. And I teach at a yoga studio in the community. And my question is, at the Zakim Center, are your acupuncturists and massage therapists, are they full-time employees of the Zakim Center, or do you partner with sort of outside organizations to get that done?
Great question. And thank you for the work you do as a dietitian. I always tell people that, PAs, NPs, doctors are all very well-meaning when it comes to nutrition advice, but it's the dietitians that are the true experts. So thank you for that, and for being a yoga instructor, and congratulations on being a cancer survivor. So yes, at the Zakim Center, we have our acupuncturists, our massage therapists, all work in a mostly full-time capacity with us. Most of them have private clinics as well. But our lead acupuncturist just celebrated 25 years with us, and he has authored a lot of the research on acupuncture in this space. So all of our practitioners are trained, in the oncology realm, but also have access to all the patient medical records, so safety can be paramount in that case. So yes, they are certainly employed by us, and we're hoping to train more acupuncturists out in the community, so we can say, okay, like, I understand you don't want to drive 2 hours to come to Boston for this. There's somebody in your area that I can refer you to. We don't have that yet, but that's the intention. Yeah. Does that answer your question?
Yeah.
Okay. Thank you.
Hi there, my name is Jason. I'm also a dietitian. I run a practice here in Rhode Island. It's a mind-body focused practice, so I appreciate this part of the talk. I have a policy-oriented question for you. So in addition to the client work I also do a lot of strategy around food policy for Rhode Island. One of the challenges that we face right now is with regards to budget in our state. So I'm wondering how the Zakim Center engages advocating for policy changes, more broadly Dana-Farber. Some of the organizations in our state, they do incredible work, and then when it comes down to really stepping forward on behalf of patients and folks in the community, we end up having to change a lot of the language in the letters that we're asking them to sign on to, or they're just not able to commit to really, be that strong force to get more funding. And I know we have representatives from the Department of Health here. So yeah, I would love to get your sense on that, and if also that is outside of your wheelhouse, I understand that as well. Thank you.
Thank you, and thank you, Jason, again, for the work you do as a dietitian. It is a little bit outside of my wheelhouse, and it's true that the policies do need to change. We do need to make more healthful food available to people, because it's easy for me to stand up here and talk about eating a diet rich in, fruits and vegetables and whole grains, but many people live in a food desert, or other social and economic factors can preclude them from eating a very healthy diet. So it's truly, I'm glad that you do work in this space. It's something that's a little bit outside of my area of expertise for sure. But I know, at least at Dana-Farber as an institution, we do have, a resource department that does support people with food cards and things like that if they need that. So we do have that to fall back on. But truly, the advocacy work is needed to avoid that type of thing, to just make this more available and priced at a at a level that doesn't make people think about, do I eat healthfully or do I put gas in my car or do I pay my rent? Yeah, so thank you for the work that you're doing in that regard.
Awesome. Thank you.
Yeah.
I have a question for you, Dan. We always talk about data-driven results, and that comes from clinical trials. But whenever we try clinical trials in integrative medicine, standard medicine says, oh, there's too many variables. We can't tell you if what you've intervened was helpful. So we always lag behind in that. And we try, for instance, my discipline is spirituality. And it'd be very tough to deny someone a time of prayer or quiet, that would, and at the same time, how do you judge whether meditation or quiet or a person's personal spirituality would help them without a clinical trial? Are there research going on at the Farber that's doing interventions or limiting interventions that can be determined to be qualitatively, statistically relevant?
Yeah, it's true. So if we're observing people over time, we don't always know if it's, is it the mindfulness that helped or is it just, something else in their life? And this is kind of what I was getting to with a lot of the exercise research being confounded by other healthy person variables. So right now, we're not doing any sort of research in that particular space, but a lot has been done. There have been a lot of randomized trials that have looked at things like mindfulness-based interventions, where they would randomize people to either receiving that intervention or some type of enhanced self-care, like a booklet about it. And they found that the effects were pretty great for the people that were in those trials. But it's true, we do need that gold standard research so we can legitimize this field more, because there are plenty of people, even at Dana-Farber, that say, well, I don't really believe in this, and so we need that data to help us really understand and make us more legitimate in our field. And that's coming for sure. And we don't always have the deep pockets that pharmaceutical companies have to conduct these trials, but there are plenty of grants available that we're constantly looking at to create these trials in diet and exercise and other self-care realms to support our patients, primarily, but also to, win the hearts and minds of our colleagues so they send more people to us and believe in what we're doing. I don't know if that answers your question, but that's my answer.
Another area that we were working in was support groups. And I think in the 80s, there were some studies done on support groups. Now, the danger of support groups, from my personal experience running a prostate cancer support group for 20 years, is when one of the people in there finds something that they like. For instance, in the 90s, it was saw palmetto. That was the be-all, cure-all. Then everybody in the group was onto saw palmetto, and nobody was telling their physicians. I don't know, do you have any thoughts about support groups and how facilitators would help people not to get too involved in all those alternative treatments?
That's a good question. And support groups can be really beneficial for so many reasons, but commonly we do see people saying, hey, this worked for me, why don't you try it? And I think it's always good to, communicate with, your peers and relate the things that have been helpful for you. But, I think giving the guidance that, hey, each supplement we need to treat as a medicine. So just talk to your oncologist before you start this, because saw palmetto does have some drug interactions that need to be thought of. So I think always falling back on just talk to your medical team before you start something new is sound guidance. Thank you for, do you still run that group? No. Oh, not anymore, yeah. Well, thank you for what you did. Yeah.
So if there are no more questions, I want to thank Dan for a very informative session. Thank you. It's time, each year, the partnership recognizes 2 or 3 individuals whose contributions have helped to prevent cancer and improve access to quality care for Rhode Islanders. And so This morning, we will be awarding 2 awards to individuals who have done this. So our first presenter for awards is going to be Norma Hardy. And while Norma's coming up here, just to say that before our break, there will be a list of the sponsors on the wall, and those sponsors have really helped to make this possible. It's a correction from the one that you have in your folder. So if you're looking for a specific sponsor and want to get to their table, just come up and read the board, and you'll find there's only 2 corrections, but probably one of those is the one you were looking for. So we'll just please take a look on the screens to find who our sponsors are and where they are. And I'll say a little bit more about this after Norma presents.
The 2025 Spirit Award is presented to Diane Martins, Professor Emerita of Nursing at the University of Rhode Island. This award recognizes the outstanding contributions that a person has made to enhance the mission of the partnership, a broad-based coalition of stakeholders in cancer care that coordinate and integrate processes to implement Rhode Island's comprehensive cancer prevention and control program. Diane joined the partnership's board of directors in 2015 and served for 10 years, stepping down in June of this year. She served on the steering committee, holding the offices of secretary, vice chair, and chair during her tenure. Diane was a member of numerous special groups, including the governance committee and the cancer prevention work group. As a member of the ovarian cancer task force, Diane made a significant impact on the work group's implementation of the Survivors Teaching Students program, whereby survivors and caretakers are brought together into medical education training programs to share their experiences with students regarding the signs and symptoms of ovarian cancer. She participated in the partnership's SkinCheck skin cancer screening program held at the state beaches each year. Diane is currently serving on the 2025 Summit Planning Committee and has done so in the past, including assisting with the application for CEUs. This year, Diane is serving on the subcommittee that organizes and directs the wonderful volunteers that help make the conference possible. She also agreed to help with troubleshooting and to be an attendant at the PCRI's exhibit table, where she has an opportunity to explain the partnership's work to summit attendees. Diane is a kind and respectful person who has demonstrated her commitment to the partnership by contributing many hours of her time, serving as a volunteer in a variety of tasks. Her colleagues especially appreciate her professional knowledge with respect to meticulously researching the topic at hand, and for her accuracy and editing prowess. She has been a mentor to all and a pleasure with which to work. It gives me great pleasure, ladies and gentlemen, to present the Spirit Award for 2025 to my friend Diane Martins. you so much.
Our next award presentation will be done by Regina Donald.
The Community Service Award recognizes a person or group that makes changes within their community to educate and facilitate cancer prevention at a grassroots level. This award may also recognize a person or group that acts as a significant community support to lessen the day-to-day burden of those touched by cancer. Miss Bonnie Abels was scared and overwhelmed with her breast cancer diagnosis in 2012. During those dark, early, and difficult days, she was unable to find support or community resources that could accommodate her hearing disability. After months of intense treatment and procedures, the cancer was gone, but her frustration with the lack of support for deaf cancer patients was not. It was at this time she decided to be the change agent for her often overlooked community. Initially, Miss Abels wanted to bring other women together who were experiencing the same fears and frustrations that come with a breast cancer diagnosis. Her vision was simple: to develop relationships within the medical community and bring what she learned to the deaf and hard of hearing community, all the while providing a safe and positive environment to learn and heal. She quickly discovered many of her peers craved the same thing. As a lifelong advocate for the deaf and hard of hearing community, Bonnie assembled monthly workshops on breast cancer beginning in 2015. These sessions evolved into talks on other cancers and also included discussions for both men and women. Now, after 10 years, her group has blossomed into a 501c3 nonprofit organization as a resource with stories of strong survivorship and community. So we present the Community Service Award to Bonnie Abels.
Good morning. I'm so happy to be here. I will try to speak clearly with my voice. I don't hear my own voice when I speak. So I will be signing and speak at the same time. Please bear with me. Okay. It is an honor to recognize by this committee and the partnership to reduce cancer in Rhode Island. This award gives me the strength to continue advocating for cancer awareness and prevention through screenings. My personal journey of having cancer diagnosis and being not able to find resources for support for a person like myself who are deaf and hard of hearing drove me to make a change. I am fortunate to have other dedicated cancer survivors to join me as a board member of the Deaf and Hard of Hearing Cancer Survivors Support Group. Our goal is to bring cancer awareness and survivor support to our community, and having partnership with all of you here, we get close to that goal each day. Thank you again. Let's keep advocating for a cure. Thank you. Also, I want to add one thing. 12 days ago, I lost a friend to cancer. She died on September 4th, 12 days. I miss her. Okay, thank you again.
Now, if you're looking at your schedule, this is our time for our exhibitor break. Again, what I said earlier, the exhibitors provide financial resources so that we can hold this summit every year. So they're out there, they have a lot to offer, a lot to show you, and a good experience. This is also a wonderful time to say hello to old friends and to make new friends. You know, we're a small cancer community in Rhode Island, and many of us know each other, work with each other over the years, and so it's an opportunity for us to hobnob, if you will, and also to see our sponsors. So we'll see you in about 15 minutes, and it will be me on this microphone calling you back in, and me out in the hall pulling you back in. Thank you. Welcome back. Now for the dietitians, the nutritionists that Dan deferred to, and a pharmacist, and no talk about these therapies would be complete without pharmacy in order to kind of show us and warn us what is good and what could be dangerous. It's a good complementary thing. So our first presenter is Donna Castricone. I had the pleasure of working with our two nutritionists in the past, so I know the quality and the skill that they bring to the panel. Donna is now at South County Hospital, and one of her innovative things that she's done is founded the Ready Kitchen. Now, the Ready Kitchen allows her to use her culinary skills and counseling experience to offer in-home medical treatments to people who may not be able to get to the outpatient setting. So it's a kind of a new concept is going out and being available and helping people who may be homebound to find a way to meet their nutritional needs. Tyler is at the Alpert, not the School of Medicine, but the Rhode Island Hospital. He's been doing work in cancer since he got out of his training. So that gives us about 10 years of, no, 7.
6 or 7, yeah.
7, I think it is. 7 years of expertise and dealing with people specifically affected by cancer.
Hey, Jim.
And
Tyler's also newly certified as certified in oncology nutrition.
okay, so now we have 2 certified college
CSO.
CSOs. What did we say there?
Certified specialists in oncology nutrition.
Okay, so we have those two specialists. Our third presenter is Christina Ward. Christina is a clinical professor and chair of pharmacy practice and clinical research. If you don't know academia, you kind of start out at the bottom and you become a assistant professor, and you work your butt off for a while and you get to be an associate professor. And then if you really endure and publish and do enough research, you get to be a full professor. So to have a full professor in pharmacy here is going to be very informative. So looking forward to this presentation. Thank you.
Thank you. Yay. Thank you, Jim. So thank you all for being here. I'm pretty happy to be talking about nutrition and dietitians and cancer care. So Tyler and I are going to, do I feel like I'm echoing? No? Okay. So Tyler and I are combining our superpowers today and to talk about malnutrition in the oncology setting. So when you leave here today, we hope that you have a better understanding of the prevalence of and adverse effects of malnutrition in cancer care. We're also going to review some validated tools that can be used to screen patients in the outpatient setting. And we're going to highlight a little bit about the lack of dietitians in outpatient centers. Unfortunately, not everybody has a Tyler or a Donna in their center. And then we're also going to talk about what we actually do. So what do we do when we're meeting with patients? So first, defining malnutrition. Well, there isn't really a universally accepted definition, but here I'm using the World Health Organization. They refer to it as deficiencies, excesses, or imbalances in a person's intake of energy and/or nutrients. So what that means is malnutrition can refer to someone that is undernutrition, or it can also refer to overweight or obese. So for purposes of this presentation, when we use the term malnutrition, we're speaking of undernutrition, because that's really what we worry about in cancer care. But keep in mind, the criteria for malnutrition is not based on a person's weight. So it's not uncommon for someone to have a higher BMI, but still meet the criteria for malnutrition. So where are we at? So malnutrition affects 25 to 75% of cancer patients. So that's a huge range, right? And what's really interesting is up to 50% of people have some type of nutritional deficiency at their time of diagnosis. So that's a lot. A lot of people may not, but that's a lot. And it's, when you think about it, it makes sense. By the time, you know, maybe you're not feeling well, you see your doctor, you go to a specialist, you have your test done, you know, some time has gone by, and when you actually present and get your diagnosis, you might be a little bit behind the 8 ball in regards to your nutrition. The other reason is, a lot of us don't like to go to the doctor. And especially right now in healthcare, we have a shortage of primary care physicians. So people, you know, if you aren't feeling that great, it's not uncommon to put off going to the doctor. Maybe you don't want to take the time out of work. Maybe you can't afford to take the time out of work to see the doctor. And so things basically get put off. So half of the people do have some type of deficiency, but a lot of people don't, right? A lot of people come into their new diagnosis and they're actually in pretty good shape. So the second thing, though, we want to keep in mind is that once you do start treatment, chemotherapy or radiation, that prevalence goes up. Your risk for malnutrition increases, and up to 80% of people are affected once they're in treatment. So why is that? Well, side effects, of course. As much as we're doing a really great job at symptom management and pre-medications, people still don't feel that great. You know, when they're going through treatment, they often have GI side effects. They may have taste changes. They may get full fast. They're tired. They just don't have that appetite. The other issue is malabsorption. Depending on your cancer and tumor or where it's located, you may actually be eating, but your body isn't able to absorb the nutrients the way that it should. And then lastly, there's the change in metabolism and your increased metabolic needs. You know, I hear a lot of people say, well, I'm not really eating, you know, but I'm not doing that much, so I don't really need as much energy. And I need to sort of re-educate them that yes, you do. You need that energy. When you're in treatment, your body is not only needing to keep up with the function of just breathing and maintaining your organs, but you're regenerating new healthy cells. Your body is working really hard. That chemo or radiation is like knocking out the cancer, but you need to really be fueling yourself in order to keep your energy up, to make new healthy cells and sort of keep up with the things you want to do day to day. So where does that lead us, right? Poor nutritional status leads to feeling weaker. You know, when you're not taking in what you need, your body breaks down your own muscle, your own fat, and it uses that for energy. And that's not a good thing because it happens very quickly. It ends up leading to decreased strength, more fatigue. So even sort of getting out of a chair, you know, within just a few weeks, you know, people really feel that difference. So overall, it really affects the quality of life for a person. It also decreases your tolerance to your treatment itself, and it increases the risk of mortality. So probably for most of us that have come into oncology, you know, we're all here because we want to help people, and many of us have been touched by cancer ourselves or know somebody and family, et cetera. We all want to help people get better, right? We want them to have a better outcome. So our job, though, in the Cancer Center is to help people stay on track. We do not want them to miss treatments or have any delays in treatment because we know that missed or delayed treatments lead to poorer outcomes. We also don't want them to be admitted to the hospital. Nobody wants to be in the hospital. They want to be home and they want to be able to be feeling the best they can most days and do the things they want to do while they're going through treatment. So I just want to highlight what's on the slides here, those dollar signs, because as much as we're all here to help people and to improve their outcomes, we know that the dollar signs are what drives health administrators. Healthcare is a business and it has to, maintain itself. So what happens when you are admitted to the hospital? Well, you're screened, whether you know it or not. Everybody is screened for their nutritional risk. And if you are deemed at risk for malnutrition, you are referred to a dietitian. So hospitals, JCAHO, they mandate that your nutritional and functional status is screened within 24 hours. So those are protocols that are in place. Hospitals have dietitians, they have lots of dietitians. We are always there, always working. So when you're inpatient, you're screened, you see a dietitian, they will meet with you, they come up with a nutrition plan, they work with the health team, and they document that. And they also continue to monitor you. So you're gonna have a follow-up within a couple of days or 4 days, depending on how you were deemed at risk. So it's a very formal process that happens. And why is that? Well, we know that early screening and treatment of malnourished patients, when they're admitted, can reduce their hospital stay by almost a day and a half. So that's a big deal. So as soon as you come in, they are going to work on getting you out. If you're admitted for pneumonia, right, you'll be in for a certain amount of time. But if you're admitted to the hospital with pneumonia and you're also pretty malnourished, for whatever reason, it could be you have food insecurities at home, you live alone, not a lot of support, maybe you have other comorbidities. Whatever the reason is, your hospital length of stay is probably going to be a little bit longer because it's going to take the team a little bit longer to get you where you need to be in order to discharge you. So this process really takes place and is a very formal process. So my question today, our question today is, why don't we have a formal process like this in the outpatient setting? So 90% of cancer patients are treated in the outpatient. They're not treated in the hospital. And if you are a cancer patient and you're in the hospital, you will eventually be a cancer patient in the outpatient, right? So why aren't we doing a better job at screening and staffing our outpatient centers with registered dietitians to address their nutrition? Excuse me. So, back in 2019, there was a study and it showed actually 50% of cancer centers were screening. They weren't necessarily very consistent, they were using different tools, but ASPEN, the American Society of Parental and Enteral Nutrition, they did this systematic review and they decided, okay, we want to answer 3 questions. We want to know, should we be screening in the outpatient centers? What tools should we be using? And then what do we do with that information once we have it, right? So I'm sure everybody can guess where this is going, right? They figured out that not all cancer patients are malnourished, but they are all at risk. And they should therefore be screened periodically using a validated tool, and then there needs to be a nutrition-focused follow-up plan for those at risk, right? So that makes sense. They also figured out that there's actually, they came up with about 6 validated tools that could be used in outpatient cancer clinics. And this is important because one size does not fit all. And when we're thinking about a screening tool, first thing you think about is, oh, that's more work for the staff and how are we going to do that and follow it, et cetera. But they came up with 6 tools with different cutoff points, which means there's different ones out there. And so there is something that can fit your cancer center. Screening tools should be easy, they should be quick, they should be valid. So I'm just highlighting a couple of them here. They're common ones. This one up on the screen now is the MST. It's a screening tool. It's 2 questions. It's used actually inpatient as well as validated for the outpatient. The next one on here, this is the PG-SGA, the short form. This is the one we actually use at the clinic that I work at. I like it because it gives you a little more information on the patient's symptoms that they're having. But again, they're 2 totally different forms. There's other ones out there, different cutoff points. So finding something that works into your system can be done. So what does that mean? Consistent nutrition screening is the critical first step in identifying patients that are at risk for malnutrition, right? So if you have a system in place, these screening tools should easily refer to a dietitian, right? It should be something that's just sort of streamlined into your process. And we know that when medical nutrition therapy is delivered to oncology patients, we can improve their clinical outcomes, right? So how come we don't have dietitians in all of our cancer centers? That's the question. We need screening tools, we need dietitians to be there to do these assessments and to really work with the team and work for the patient. Because we know that the later nutrition care is implemented, the more difficult it becomes to manage and optimize. So with that, I'm going to pause. I'm going to turn the clicker over to Tyler, and he's going to talk about what we actually do. What are dietitians doing in the clinic when we actually get those referrals and see patients?
Thank you, Donna. Okay, so one of the things we're going to be talking about is what we do, and a big point is that everything that a dietitian does is with intention. We're not diagnosing malnutrition willy-nilly or because someone's weight looks a little bit off. There are very specific criteria by which we are using to diagnose patients, and by being able to intervene earlier, we not only improve outcomes, we also acquire additional reimbursement for inpatient facilities, which is important because, as Donna mentioned, longer hospital stays are associated with patients that are malnourished, and as a result, their healthcare costs are higher. So we're going to be talking a little bit about the framework for malnutrition and how it's diagnosed through the American Society of Parenteral and Enteral Nutrition. I do not expect everyone here to become an expert in the specific criteria, but just to kind of frame things, it's based on energy intake, weight loss, muscle and fat loss, fluid accumulation, and hand grip strength. As you can see, there are different criteria based on the duration and severity and the etiology of the malnutrition, but weight is not one of those criterion because patients can be undernourished even if they are overweight. There is a lot of weight bias out there, unfortunately. It's important for us to put that aside and recognize that even if a person might look properly nourished, there is a wide range of things that could impact that. So, I think one of the big things that we like to focus on is what we actually do. It's one of the points that we have that we were designed to kind of advocate toward. We're not going into a patient's room to take their order or anything like that, even though that is an important part of the hospital stay. So I just want to share that nutritionist is not a term that is specific in what is required of that person. It's not a regulated term, so anybody could call themselves nutritionist. A registered dietitian is a person requires a specific amount of education. As of 2024, a master's degree is required. You need to undergo practice hours that are supervised, at least 1,000. You have to pass a national registration exam, become licensed, and you have to continue education to keep up to date with a focus on ethics. We practice medical nutrition therapy, which is evidence-based practice, and we are not out there to give people information to sell them products or to try and give them a miracle cure-all. We're using information that is based upon research and is practical in its application. So it's always important to make sure that you are working with a credentialed expert. And I also want to thank our keynote speaker, Dan, for pointing out that the dietitian is an important piece of this puzzle because a physician's assistant or a speech language pathologist is not a dietitian. They have expertise that we don't have, but we have expertise they don't have. So that's why we look at things in a collaborative approach. So when we think about what a dietitian does, there's a lot of different moving pieces. We work with patients in the prevention, treatment, and survivorship after their treatment, and we'll talk specifically about some of the things that we do. But as you can see, we're doing a lot with symptom management, we're doing a lot with optimizing nutrition care, and sometimes I think one of the interesting things is that our interventions sometimes seem kind of basic or not super flashy or exciting compared to the stuff you might see on social media, but there's a reason for it because it's evidence-based and it's designed to be to have high efficacy. When we think about some of these things, it might seem simple, like if a person is experiencing lack of taste, we might tell them something like, we're in a wonderful time. We no longer have to ration flavor for the war effort, so we can add additional seasoning to food. That's simple, but it's effective, and it's what we do. So I want to kind of go through a little bit about, like, if I see a person come across my desk, what goes into it. We don't just go there and say, you need some protein, now get out of my office. There's a lot more that goes into the process. So we're reviewing and interpreting medications, lab work, weight trends, nutrient-drug interactions, their chart, and the care plan where they are with treatment. We're speaking with people to understand what's happening and where we need to go. We're discussing and assessing physical manifestations of things like malnutrition, micronutrient deficiencies, and side effects. I think one of the most important pieces is that we provide emotional support, encouragement, and empowerment. As Dan had also mentioned, autonomy is an important piece of this, and unfortunately, cancer diagnosis takes a lot of that away. So we're creating a plan together to say, like, what are the issues that are assessed? What can we do? And when I say we, I don't say me. It's us as a team. We're trying to work together to give the person a sense of agency to say, I have some degree of control in a system where I do not have much of that. We also are here to help cut through the heavy fog of misinformation and provide evidence-based recommendations. I think an important piece of this is with TikTok, with Twitter, with any social media platform. There's flashy information out there, and just because it's flashy or said really loud does not mean that it is always accurate. We also coordinate care with other providers and disciplines, for example, speech-language pathologists, physical therapists, our palliative care team, and we work together to monitor and follow up. So one of the things that's important for us to kind of highlight is a requirement for what we call nutrition-focused physical assessments. What we're doing is we're trained to assess for micronutrient deficiencies, macronutrient deficiencies, that kind of thing. We're using tools such as touching, listening, oscillation, and other techniques to identify a person's nutrition status. Because as we mentioned, a chart might have a number, like a weight or a body mass index, but that in and of itself is not designed to be the end-all be-all of a person's weight. So we're doing things like looking at concavity in areas like the temples or the interosseous areas or the buccal fat pads to show that we are losing muscle or fat. Looking at things like poor skin turgor, which is how quickly your skin bounces back, can be a sign of inadequate hydration status, and looking at things like essential fatty acid deficiency through things like scaly skin or through hair loss. So it might be cool to say, well, dietitians provide benefit, but what measurable benefits do we have? So we are looking at things like quality of life improvements through things like managing side effects. We help people maintain strength and energy, and as a result, improve quality of life. We're designing plans to help people get through their treatments, because as Don had mentioned, better nutrition status and less weight loss keeps people on track, and we get better outcomes. For head and neck cancer patients, as little as 1 day of treatment missed brings down the efficacy of their treatment by 1%. So if a person loses weight due to side effects and they have to take a week off from radiation, well, that significantly impacts how well their treatment is going to get the outcomes that we want. People are also hospitalized less often, which is important. We improve recovery and we maintain dignity and independence with our patients. And another part, like I mentioned before, is just being someone to listen. I think a lot of my job personally is just sitting with a person and having them feel heard and having someone that understands what they're going through. I hear all the time that someone might say, if your appetite is poor, you're losing weight, just eat. If it was that simple, I would not have a job. Donna would not have a job. There's physiological factors that are going into limiting a person's appetite. The treatments are causing things like taste changes, and people are in a very stressful situation. So I think sometimes just having someone that's in their corner to speak with them and be there for them is one of the most important pieces of our position, on top of providing medical nutrition therapy. So with all of that being said, Donna was alluding earlier about, well, what can we do? What do we need to do? What are some glaring flaws? And as we were kind of talking about before, we're just kind of asking rhetorical questions around, like, how are we screening for malnutrition? How is your clinic working? How effective is the referral to a dietitian? Is it something where someone writes a note down and it never ends up on their desk? What is your policy? And do you have dietitians that are dedicated to your facility to see the patients that are as vulnerable as they are? And how can we improve what we're doing? I do not expect every single one of these questions to be answered in this room today or next year or the year after, but these are just things for us to consider, and we're happy to discuss this after the talk kind of as a small group, just to kind of have everyone on the same page and get other people's experiences. We do have references, and we appreciate your time. We'll be turning our discussion over next year.
Thank you. I'm actually going to stand. Whoa, I'm creating a scene already. I typically am like a walker. I like walk back and forth, but I'll stand up here today. I'm going to try to make this so it doesn't fall out of my pocket again. All right. So awesome. I love it. I love what you're doing, and I love your theme about evidence-based, because a lot of what I'm going to talk about today has to do with evidence.
Absolutely.
And I wasn't able to be here this morning for the keynote speaker, but I heard that he also talked a lot about evidence. So let's see. Okay, here we go. So I am so grateful to be here. I didn't actually know about this group and how awesome it is to be here today. My colleague who couldn't be here today, Pat Skeffington, is a pharmacist at South Coast Health in their Comprehensive Cancer Center, and he talked to me about getting involved. Pat, let's see, here we go, forward. So Pat reached out to me about 10 years ago, a faithful alumni of URI College of Pharmacy, and he's like, Christy, we have a problem. We're getting ready to implement in our cancer center a pharmacist intervention with all new initiations of oral chemotherapy for our cancer patients, and we noticed right away they're taking dietary supplements, and we don't know how to answer questions about interactions. So I've been working with Pat for about probably over 10 years now. When they have questions about dietary supplements or natural products, they reach out to me. So my background at URI is that I specialize in a field we call drug information, and basically all of the really hard questions come to me. So it used to be, before we had the internet and widely available references, that everybody called me, right? I would get hundreds of questions, and I had the key, right? I had the database. Now we get many fewer questions because that information is more readily available, but the questions that I get are pretty complicated and complex and take a lot longer to work on. So Pat couldn't be here today. He has an imminent visit from the Joint Commission that you talked about, so everybody knows when you're on alert, you have to be there. So I'm going to be presenting the information for him. We did talk about his portions so that I could have perspective to share with you. So before we get to that point, our objectives today are really to summarize the process for oral chemotherapy new initiations at South Coast Community Cancer Center. And then I'm going to really talk about the complicated regulatory status of dietary supplements. Some of you may be wondering why I am up here talking about dietary supplements with the two dietitians up here, right? And it's because dietary supplements are actually regulated as foods, right? So we'll talk about that. Then we're going to go into a little bit more about how interactions, drug-drug interactions, but also drug-supplement interactions can occur, and we call that pharmacokinetics and pharmacodynamics, and I'll explain that a little bit. We'll go through the strategies that we use at Drug Information Services when we're answering a question about potential interactions, and lastly, we'll kind of wrap up discussing the risks, the benefits, and the limitations of the data. So at South Coast Health, in their oral chemotherapy process on day one, or excuse me, cycle 0, day 1, it's really a collaborative process, right? It starts out with a nurse practitioner doing a teaching about oral chemotherapy, safe handling, the treatment calendar, what's a cycle, all of that important information, and provides drug information, initial counseling as well. At that point, the pharmacy team will do a drug-drug interaction check with the known medications that the patient is taking, and then also with the new oral agent. And then they'll work with a liaison from Shield about affordability, because as we know, these medications are pretty expensive, and so they're going to identify if this is a covered agent or work to find financial assistance if they can. On day 1, the patient is scheduled for a follow-up, and then they'll have a nurse navigator who will complete an oral chemotherapy adherence phone call. Again, just checking in to make sure that everything is going okay with the patient very early on. Frequent touches improve patient adherence. When we get to cycle 1, day 15, the pharmacy will have a 30-minute consult with the patient, and this is called, they perform what we call a brown bag. Anybody ever heard of a brown bag? Yes, no, yeah, oh good. So basically bring everything you take. Bring all your medicines, bring your over-the-counters, bring your supplements, your vitamins, all of it in a bag, and we're gonna dump it out on the table and we're gonna go through it. And for real, the things that people bring in are amazing and interesting. And I don't want to sound not respectful, but the amount of misinformation out there is a lot. We also have in the area where South Coast serves, right, Fall River, Fairhaven are their clinics. There's many people from other countries that use natural products more frequently, so we also have that playing a role as well. So we will go through the oral chemotherapy, all of the stuff that they're taking, and basically what we want to do is make sure that we have the most up-to-date med list possible so that everybody on the team is aware what the patient is actually taking. At this point, they're going to rerun a drug-drug interaction once we find out everything, right? And that includes with their dietary supplements. Now, unfortunately, some of our standard resources that pharmacists use are limited in the amount of information they have about interactions with dietary supplements. And that's where I come in. So they will reach out to Drug Information Services and will help them identify if there are any potential issues. And at that point, they're going to recommend to the care team that the patient hold the dietary supplements until we can perform a more in-depth analysis. I think the one thing that Pat wanted me to emphasize is this is a collaborative process, that everybody has a role in ensuring the patient has the best possible experience and outcome. So I just want to frame the issue of dietary supplements. And, you know, back when I was in pharmacy school, dietary supplements were out there. It was a $4 billion a year industry. There were about 4,000 products that were marketed. We thought that was huge, right? Oh my gosh, $40 billion a year. Fast forward to 2020, it's a $40 billion a year industry, 50 to 80,000 dietary supplements on the market. It's just enormous. And so I've noted on the side here that we have vitamins, minerals, plant extracts, animal extracts, hormones, amino acids, all fall under dietary supplements. I cringe a little with animal extracts. I cringe a little some of these, but animal extracts in particular, we're talking about ground pancreas from pigs. We're talking about other organs from other animals that are being ground up, not cooked raw, right? So there are definitely some concerns about contamination and infection that could result from that. So that's just an aside. That was a little extra, sorry. When we talk about the regulatory status of dietary supplements or natural products, it falls under the Food and Drug Administration, which is why I'm up here on the stage, on the same stage, right? And in 1994, the Dietary Supplement Health and Education Act was passed, and it really provided some additional guidance for how the FDA can regulate these products. And let's just say they really can't regulate them. They have no authority to regulate effectiveness or efficacy. So when we have an FDA-approved drug, right, it has to go through studies. We all know safety is paramount, right? But also studies to prove they work are required. Dietary supplements don't have that requirement. The FDA also does not have any role in pre-market inspection of facilities that manufacture dietary supplements. This is also a problem because post-market inspections reveal inaccurate labeling and claims that don't align with what their experimental data, if they have it, say, right? So there's a lot of issues that come up with the relative inability of the FDA to do any pre-market regulation. They do, however, have some post-marketing capabilities. So what that means is manufacturers are largely responsible for evaluating safety of these products and ensuring that the labeling meets the requirements of DSHEA, or the Dietary Supplement Health and Education Act. I think I'm just making sure that I don't miss anything because, right, so the one thing that I do want to say when we talk about ensuring labeling meets those requirements, this means that the manufacturer is asserting by labeling their product that they are not misbranded or adulterated, right? So there's no contamination, or everything that's in the bottle is what's supposed to be in there, all the ingredients. So this is what they are basically asserting. So advertising and loopholes, I think that kind of says a lot, and I'm sorry that I'm Debbie Downer. I do know that the keynote speaker today was also alluded to some of this. With dietary supplements, they can make three types of claims. One is called a structure-function claim. The other is a claim on general well-being, and the other is a claim about nutrient deficiency. So function claims are the ones that we probably hear the most, right? So there'll be things like calcium builds strong bones. Okay, so what does that mean? Calcium builds strong bones. What would we anticipate should happen if we have strong bones, right? There's some outcome that is averted, right? That outcome is a fracture, right? So by saying calcium builds strong bones, it's not really telling us anything. They are making an assertion. For drugs that are on the market, FDA approved for people who have osteoporosis, they had to go through clinical trials to prove that fractures are reduced with their product, right? Some of them in the early studies talked about bone mineral density, right? But then they moved on to fracture prevention. So this is the difference between a structure-function claim and a claim of efficacy. Fiber maintains bowel regularity. Antioxidants maintain cell integrity. These are all very large, unmeasurable claims, right? If the company makes a structure-function claim, they have to disclose on their label that the FDA has not evaluated that claim, and they also have to put on the label that this product is not intended to diagnose, treat, or prevent any disease. Great, okay? So now remember where I told you that the manufacturers of dietary supplements had to evaluate safety. Guess what? all they have to do is self-affirm that the product is safe, right? So most of the companies that produce these products use a pathway called the GRAS pathway, which is generally recognized as safe. The GRAS pathway, if they market a product that is a GRAS food, all they have to do is say, it's safe. Okay, they don't have to provide data. There is a pathway, right? The new, I had to write this down, new dietary ingredient notification, the NDIN pathway at the FDA. But by using the GRAS, the GRAS pathway, they circumvent the new dietary ingredient pathway, which would require more information. So this is a huge loophole, in my opinion. It's well known. It creates a lot of challenges in the dietary supplement industry. Some of the other challenges, right? Undeclared or banned ingredients, right? So we specifically see a lot of these undeclared or banned ingredients in supplements promoted for weight loss, right? Or for muscle building or enhanced sexual function. Right, these ingredients may actually be FDA-approved drugs, but they are somehow in this dietary supplement. Remember, because the FDA does not do pre-market inspections of the manufacturing facilities and doesn't have authority to ask for data for proof, right? So that's a big problem. The FDA does have ability to recall or ban dietary supplements, right? However, it's not fast and it's certainly not easy, and it definitely costs you, the taxpayer, a lot of money. For ephedra, which we know has cardiovascular adverse effects, it took 7 years to ban ephedra, and I believe that one went to the Supreme Court. And another dietary supplement, 1,3-dimethylamylamine, which is a derivative of amphetamine, which is probably not good to have just on the general market, that also took 7 years. So this is, while they do have the authority to remove these products from the market, it takes a long time and a lot of money. And in the meantime, they're available. Patients can be taking those, consumers can be taking those and having adverse events. There's another tiny, tiny loophole, or I don't know, loophole or problem. If the dietary supplement is tainted with an FDA-approved drug, the FDA technically for medications cannot remove something from the market. They can suggest to a manufacturer that it be removed, like strongly suggest, but they can't actually force that to happen themselves. If there is an undeclared FDA-approved drug in that supplement, there's a real question on whether the FDA can actually have the manufacturer of the dietary supplement remove that from the market as well. So a bunch of stuff going on there. All right, enough about laws and stuff. Let's talk about interactions. So it kind of fell off my slides a little bit, but we divide this into two primary mechanisms, right? So pharmacokinetics mechanisms, where pharmacokinetics is how the body acts on the drugs, right? So this is where you have interactions that interfere with absorption, distribution of the drug within the body, how the body metabolizes the drug or supplement, and how it's eliminated, right? So if anybody's ever had the fun opportunity to take doxycycline or some other antibiotics, we know that calcium containing products and antacids interact, and we have to separate them. And that's because the calcium, excuse me, the calcium or the antacid interfere with the absorption of that antibiotic, right? So these are the types of interactions that are pharmacokinetic interactions. We also have pharmacodynamic interactions, and pharmacodynamics is how the drug works on the body. So we can have synergistic effects, additive effects, and antagonistic effects. So synergism is when 1 + 1 = 5, right? We have a drug and we add this other drug. Sometimes we do it on purpose, or we add a supplement and we get this way greater than expected response. That's synergy. Additive response is when we have 1 + 1 = 2. We just add a second one on. It's exactly what we predict it would probably be. We just add the effects into a cumulative effect. We have other situations where we have a medication, we add another medication, it actually decreases the effect of one of the two, right? So that we call that antagonism. And we can apply these principles to drug supplement interactions as well. And then I just kind of put down there also that sometimes I'm not just looking at drug supplement interactions. Many times I'm looking at supplement disease interactions, right? So does the supplement actually work in a way that could worsen the cancer process? And that unfortunately can happen. So once we get a call from Pat, we kind of get our bearings, right? We look up what ingredients are in the dietary supplement. Boy, wouldn't it be great if it was only 1 or 2? It's like 15 or more, right? We also have some situations where dietary supplements list their infamous or famous proprietary blends, which it doesn't actually tell us what's in there all of the time. And if it does, it doesn't tell us how much because that's proprietary. Makes it very difficult to answer some of these questions. We look at what the claim is and is there any historic or folkloric precedent for what this is being used for. After we kind of do that background, right, we'll go and we'll do a tertiary search. And here we have some proprietary databases of information. Again, these primarily are limited in the amount of information they have about dietary supplements. These are things like Lexicomp, which also publishes UpToDate, which some of you may be familiar with. UpToDate frequently gets its information about medications from Lexicomp. Facts and Comparisons is another database under the Lexicomp umbrella. They have a dietary supplement section or a natural product section that's been around for a while called, well, it used to be called the Lawrence Review of Natural Products. Now it's just called Natural Products on their website. That is more botanical in nature, so if we have purely botanical supplements, it may be helpful, but if we have this mixture, we have ground animal organ, like we're not going to be able to get everything we need from there. Micromedics, for those of you who work in a hospital setting, you're probably familiar with Micromedics, does have some information. But the one that probably has the most information is a database called Natural Medicines. And this primarily is the function of this database to look up information about natural products. There's also some freely available websites about natural products. Some of you may have heard about the Memorial Sloan Kettering About Herbs website that has a patient side as well as a health professional side that can be helpful, although not all-inclusive. And then you can also find, if you really look hard, the German Commission E. Again, the German Commission E was in Germany, obviously. In the 80s, it functioned around the 80s and the 90s, right? So the information there is kind of limited, again, very botanically based, very little about the clinical use of these botanicals. Once we finish our tertiary search, we go to primary literature, PubMed. Sometimes we'll go to Embase, which has a more international coverage. And here's where we're really going to find the information that serve as the basis for why some of these products are being used. And many times we will dig down and we'll find out that this is based on a cell culture or a test tube data. Sometimes in animals, if we're lucky, rarely, if ever, clinical trials. If we do have evidence of use in humans, it's case reports, which are great, but they're N of 1 and they cannot really give us, you know, really solid information. So what are our pitfalls? Well, the biggest pitfalls is there's no data, right? So when we're using these products, they claim a lot of things. It's based on very little. I could probably think of, on one hand, the number of dietary supplements, nutritional, or natural products where there actually are large clinical trials, but they just don't happen because they don't have to, right? These can be marketed without any evidence, just claims. So why would we spend money to do those trials? They're not done. But we do know that there's a lot of them. We know there's a lot of claims. We do know that we can look at PK and PD, pharmacokinetic and pharmacodynamic data in cell cultures for example, cytochrome interactions, but that is not representative at all of what we're likely to see in humans. We would be extrapolating greatly for these types of interactions. But what it comes down to, even if we have this information and we try to extrapolate it, we can really never know the true effect that's happening in you, the patient. And so, you know, this is a hard situation for, I think, healthcare providers to be in. So what are the risks and benefits? So the risks are, we could have an effect on your chemotherapy drug that increases the toxicity. Maybe it prevents your chemo from being metabolized, so you have that active drug more available, and that's going to result in more toxicity. That's pretty bad, but also bad is it could decrease the effect of the chemotherapy, right? Or it could interact with the disease. The benefits, I really had a hard time. That's why I put unspecified benefit. But the one thing I will say is, and I have not had cancer, and I can only imagine what it's like to not be in control of your future. And especially in a situation where all of these things are going on around you, you've got these medications that you're taking now, and there's just a ton of them, and you have side effects. It's nice to have something that you can be in control of, right? And for some people, dietary supplements and natural products might represent that. So I understand that, but also the pharmacist side of me is like, but there's no data. And so you really have to balance, like, what are the potential risks for this patient? Oh, by the way, has the patient already been taking it and didn't tell us? If they have been taking it and didn't tell us, then maybe we'll just monitor them a little more closely, but let them continue. So one of the things I remember when Pat first talked to me about this was they want a cheat sheet of the interactions with dietary supplements and chemotherapy. And I'm like, okay. So I went back over the past year and looked at all of the questions that we had done, and I'm like, there's really no way I can put this into a cheat sheet. So what I will say is I have a few examples here. So the first is interactions with anticoagulants and antiplatelets. As you know, some cancers are prothrombotic, right? So you have an increased risk for forming clots. And so patients may need to be on an anticoagulant or an antiplatelet agent. We do have dietary supplements that have those very same effects, right? Fish oil, garlic, ginkgo, saw palmetto, turmeric, right? All have anticoagulant or antiplatelet activity. So if we administer those while we have a patient taking an anticoagulant or antiplatelet, are we just making it better so there's even less chance that they're going to have a clot? Well, usually that means that, one, we either bleed more or we can't stop bleeding. So that might not necessarily be a good thing. The other, I can't remember who, I think Jim, we were talking about saw palmetto, right? The latest saw palmetto for me is turmeric. Everybody wants to take turmeric, right? The problem is turmeric goes through the CYP3A4. This is a metabolic process in the liver. And so it interacts with a lot of medications. It also interacts with alkylating agents, anti-tumor antibiotics, tamoxifen, a lot of the drugs that we use for treating patients with cancer. So I'm always cautious of turmeric. And the other example I wanted to give, because this has come up multiple times over the year, is some of these dietary supplements have an estrogenic compound or activity. And so if we have a patient with a hormone-sensitive cancer, this could be very bad, right? So we're talking about things like Asian ginseng, which is different than American ginseng, Asian yam, Asian peony, horny goatweed, which always makes me just chuckle because who comes up with these names? Deer antler velvet, that one sounded very interesting to me because again, the whole idea of putting ground animal products into something that I'm ingesting into my body is concerning, and dong quai. And again, this, I think the one that got cut off is soy products, right? So soy is known as a phytoestrogen, and there's some controversy over whether soy actually is bad in hormone-dependent cancers, or maybe it's helpful. But what it comes down to is we really just don't know if it's helpful or not, or if it's dangerous. So I thought these were some to think about. So in conclusions, I would say dietary supplements are regulated very differently than drugs, and surprisingly different probably for many of you. So it's really important that we identify when people are using them so that we can at least assess for potential interactions with the limited information that we have. I think partnering with your pharmacist is essential here. And again, I'm happy, to extend drug information services open to everyone, all healthcare professionals. So that's an option as well. So anyways, I think that's where I'm going to stop. I did forget to bring my business card. So if you have any questions and you want to reach out in the future, you can go ahead and email me. It's kward@uri.edu. And I think I'm going to turn it back over to Jim for the remainder of the panel discussion. Oh. Yeah, you're welcome.
Great information.
So thank you to all three of you, Donna, Tyler, Christina. We have time for a few questions. Again, the microphones are up. Did somebody tell you guys there are snacks outside? Yeah?
Ooh, I have a question for Christina.
Okay.
So are there cutoff points for, like, when someone is using a fish oil or a turmeric or something like that? Is there you would say it's okay if they're taking this much or below, but it's when it gets to a higher amount, that's when it gets tricky, or no?
This prompts me for a really good thing that I didn't bring up. First and foremost is that many of you might say these products are all natural, right? Turmeric is all natural. We can get it in the diet. I'll just remind everyone that cyanide is all natural, right? Paclitaxel, right, for chemotherapy, we get from the yew tree. We have the vinca alkaloids. They can be toxic. Your question is specifically about cutoffs. So fish oil is tricky because there actually is an FDA-approved fish oil, right? So we probably have a little more information with that. For the rest of them, no information about cutoffs, right? More, but honestly, when you're taking turmeric in a capsule, you're getting a lot more turmeric than you would normally get in a diet. So I think anytime you're taking a dietary supplement or a natural product, you're getting more than you would get in your diet just in that one capsule. So I think the cutoff is you've well surpassed what we would know.
Got it. Thank you.
Thank you. Joe?
Thank you for your presentation this morning. I think it was extremely enlightening to me as a caregiver of a wife who's been in cancer treatment for 22 years. And one of the things that I wanted to comment on with regard to your talk about supplements, I think when a person gets a diagnosis of cancer, for that person and for the family members, there's a real sense of vulnerability. And everybody's got a recommendation on what you should take to help your problem, right?
Yeah.
And I remember when we first started in this journey, someone close to us recommended a product by a company, I won't mention the name, but it was a powdery form. It was like Tang, and it was about $130 a shot. And when you're a family member, you want to do the best that you can for your family member, you'll spare no expense. And I know we spent a few $1,000s on a product that in the end probably had absolutely no benefit to my wife at all. And that's how you can kind of get sucked in. I don't consider myself to be, you know, kind of living under the covers, but I was so wanting to do everything possible. So I thank you for that, because oftentimes it is very tempting to say, well, maybe this supplement would help. As far as the other presentation on nutrition and dietitian, I think it's helpful as a caregiver. Again, my wife was diagnosed 22 years ago. She walks out with a cancer diagnosis, and I walk out with a label caregiver. I have no job description for caregiver. It's like, do everything. So if I'm doing the cooking, I don't know, you know, she comes back from a treatment, she's not feeling like eating, it doesn't taste good, I can't taste anything, or this or that. You know, I don't know as a caregiver what I should be doing to make sure that my wife gets a proper nutrition. So I guess this is a long-winded way of saying, is there something out there that's sort of, you know, you mentioned that you've got a couple of screening tools that you use that would help a caregiver who is trying to do the best they can for their family member, and would help them out in those situations. The person says, I just don't feel like eating anything. You know, they should. You know, the treatment is dragging them down. And I'll turn it over to you.
Do you want to take that, Tyler, or
Sure.
shall I?
So there's a few different things to kind of go through with that. I think one of the most important things is that you should be connected with a registered dietitian, because it is not your job to have to navigate this process alone. It's very broad, scary, and overwhelming. And I don't think that it's fair to assume that the caregiver should have to figure everything out, because there's so much good and not so good information. So I think if you're not set up with a dietitian, I think it's important to speak with your oncologist about getting a referral to a dietitian. And with that, it's tough because there's different ways by which we manage these problems. For some people, we're looking to manage things like hypokalemia, low potassium. There's other people that are having trouble maintaining their weight. There's people that are having problems with their taste. So as a result, not one specific piece of information is going to help everybody. I will oftentimes reference things such as MyPlate, which is through the USDA, or the American Institute on Cancer Research's New Plate, which is a plate model that kind of helps to say, like, we want these basic food groups with our meals in these proportions to have general adequacy in our diet. But how is a caregiver, or how is somebody to know if they're getting enough? That's where the expertise of a dietitian is very important. So I think it's good to get general information, but there's a lot of specificity that does require additional nuance to figure out.
I just want to add too, like Dan had mentioned this earlier, that if there was a pill for that, we would all be taking it, we would all want it. I mean, I think we all want the easiest route, like something, oh, okay, here's what you got to do, and that's what you do. But unfortunately, it's not easy. It's very individual, and food is very personal. So it really does take, you know, like a conversation and really listening and working with the patient to figure out what that patient and their caregiver needs. You know, so the recommendations that we give are really individual, and because, you know, what I tell one person may not work for somebody else. So it really is important to have that relationship.
Thank you. Last question.
All right, so to wrap it up here, this is maybe a question more for Donna and Tyler, but also maybe you, Christina. I'm a dietitian, however, I don't work in a cancer center. So I'm curious, what are, maybe for each of you, like the most common like misconceptions or myths that you hear, and how do you typically respond to that?
There's a couple that come to mind. I don't know if you want to share one, and then I can kind of do it one that you haven't shared, or if you want me to go first, you tell me.
Myths, well, you know, it's not necessarily a myth, but I do feel like Everybody wants to know the one food. Okay, well, what should I be eating? Everybody wants to know what the answer is, and it's like, well, there isn't any one food. That's what I usually say. I mean, our bodies are really complicated beings, and we need so many different macro and micronutrients to function properly. So I really try to stress color and variety. And I think that's much more important than, so if you don't like blueberries, well, then that's fine. Even though they're a superfood, they're not the one food. You can still be healthy and have a good diet. So I don't know, that would be the first thing that comes to mind.
I'll share, I think, probably the most common question, one of the most common is about sugar. Sugar feeding cancer. And it is easy to think that, but because the way that our bodies work is when we consume carbohydrates, whether they're from natural sugars like fruit, a candy bar, juice, a soda, they're broken down to carbohydrates and our cells use them for energy. That's just basic physiology and that's how we operate. So cancer cells by nature do use sugar as energy, just like all of our healthy cells. Cancer cells do have a higher rate of glucose uptake because they're using more nutrients to divide. So one might say, following a ketogenic diet, a low carb or a restrictive carbohydrate diet would kill or starve cancer cells. And what happens is all of your body cells end up getting starved. It's not selective. There is some evidence out there they talk about with the ketogenic diet for brain tumors or glioblastomas, but we're talking about just kind of general stuff here. And what I tend to find is that people will, demonize carbohydrates and lump things like, I can't eat fruit. And they'll say, like, I can't eat starches, I can't eat rice, but
bread. Can't eat bread.
First of all, bread is delicious. Another problem is that it is our source of energy in our body. So the way that I look at things is more about excessive sugar, because we do know that excessive sugar intake from things like sugar-sweetened drinks, juices, desserts, can increase a person's risk for getting cancer, along with a sedentary lifestyle and a generally unbalanced diet. But during a cancer diagnosis, if a person eats a Hershey Kiss, it doesn't make a tumor go from this to this. What we kind of promote is nutritional adequacy and having balance. And if a person has a balanced diet and they have a sweet every now and again, I'm not going to lose sleep over that. If a person does something like eating donuts for breakfast, I'm not upset that they ate donuts. I'm upset that they were missing out on really important nutrients to get their day started, like proteins, vitamins, minerals, and antioxidants. So I think it's a very nuanced thing to say, because it's very easy to just be like, yes, sugar feeds cancer. But
or don't eat white foods.
Exactly.
Anything
and like, if we're looking
cauliflower.
at ghost broccoli is delightful. Potatoes are great. There's a lot of alliums and allicin and onions are antioxidant in nature. It's not right to blame foods for the problems of people's misunderstanding and misinformation. So I think it's important to recognize that any food can fit when it's part of a reasonable plan. So we're not going to cut out, I've never cut out a single nutrient from a person's diet, like you can't eat carbs or fats or proteins, because all of these provide a specific role in our body toward recovery.
I think you'll find most dietitians are also foodies. So, we're not going to really label food as good or bad. I mean, just like Tyler said, everything can kind of fit. I had a patient once who, gosh, she felt so guilty because her friend had made her a beautiful homemade pie, and she felt like, oh my gosh, I can't eat that, the sugar in it. And I said, no, that's feeding your soul. Yeah. So there's room for pie in everybody's diet, even when you have cancer.
Yeah. As long as we're focusing on, say, moderation, having a balanced meals to meet our protein needs, healthy fat needs, carbohydrate needs, we have room for those kinds of things.
Yeah.
I always talk about it where it's like we look at a pie chart, and if a person's, say, sugar intake from desserts composes a large percentage of their diet, like 30, 40%, then they're missing out on other nutrients. Whereas if it's a small percentage, we have room to fit those in.
That's what I do say that a lot to people. It's just a missed opportunity. It's just like when somebody eats the same thing every day for breakfast or whatever, it's just a missed opportunity to get more variety and other nutrients into your day. And it's the same thing, having those sweets once in a while, is fine. But you can't do that all the time because it's a missed opportunity to give your body what it really needs to function well.
Thank you to our panel. Great discussion. Now, Donna did mention, please.
We don't have time for one more question by chance, Lear.
Okay, I just had a question. I'm a pharmacist by training. I work on the industry side now, but I did used to counsel a lot of patients, and this particularly with oral oncolytics. And it was in a rural community setting, and I didn't often have a dietitian that I could refer to, but I just wanted to know if you guys would be able to comment on dysgeusia and taste changes, taste disturbance. It's a real challenge. I think it's underappreciated how much of an impact on quality of life and even treatment adherence that can be for patients. I've known of patients to be in wonderful response to therapy, and literally choose to stop their medication because they cannot navigate this nuance to their relationship with food, and I think we probably underappreciate that. So I just wanted to hear, any thoughts on resources and how to assist patients best with dysgeusia.
Sure. So a couple things to think about. So a medication like cisplatin, a common chemotherapy agent, part of its brand name is Platinol. One of the compounds of it is platinum. And as a result, because chemotherapy circulates through all of our cells, our taste buds are impacted by this chemotherapy. And as a result, metallic compounds can sometimes make things taste weird, or just general other metabolic adjustments. So dysgeusia is very common with patients, and it's very individualized. I have some people that tell me that, I don't know, oatmeal is the most delicious thing on the planet, which, oatmeal is great, but I'm like, that doesn't make sense to me. But I always say it's like your body's setting rules and we have to play by them. So there's different principles to, that we can focus on. There's a dietitian, her name is Rebecca Katz, and she created something called FAST, which stands for fat, acid, salt, and sweet. We can use these to our advantage. Some people find that fat-soluble flavors can be better transferred to the mouth, so we'll add a little bit of extra like olive oil or cream. A little bit of acidity can help brighten flavors. A little bit of saltiness or sweetness can help to kind of alter things. As I say, a spoonful of sugar helps the medicine go down. Good oral care is super important, because if your mouth is kind of in a messed up space, your ability to taste and perceive flavors is going to be off as well. And dry mouth or xerostomia is very common. People get mucositis and ulcers, so we have to make sure that people are taking care of their mouth, and we also have strategies to improve people's dry mouth, to improve the way, the playing field by which they're able to perceive flavors. There's a lot out there too. We actually in the clinic recommend something called a miracle berry or an M-berry. It's a little thing that dissolves on your tongue, and it helps to perceive sweet flavors more, in a more kind of pronounced fashion. So some people that kind of lean into the sweetness, we use these as kind of a side effect-free way to improve taste, but there's a lot that goes into it. And I think it's important to highlight these kinds of issues, because if, like I said, if it's just as simple as saying eat, like it doesn't taste good, eat anyways.
Yeah, we wouldn't have this issue.
Exactly. So people want to eat, they just have things that are holding them back.
Thank you.
Can I say one more quick thing?
Okay, Donna.
I just want to say that the other thing too with fast fixes is I like to, instead of focusing on what tastes bad, talking to the person about what actually does taste good, and then maybe going in that direction and focusing on that. So if somebody does feel like, well, sweets are a little bit better for me, or maybe acidic foods taste a little bit better, adding a little bit of a fresh lemon or vinegars, or maybe like a sweet salsa, adding that to something. So, focusing on what's working, I think is also important, and then kind of gradually lead them in that direction with using the FASS.
Yeah.
So, all right.
Now, thank you to this panel. They did a great job. Donna mentioned, eating a lot of variety of colors. Well, on our snack, the wrappers don't count, okay? We'll take a break, and we'll be back in about 25 minutes. Welcome back to our final panel. This panel's original moderator was sick this morning and couldn't make it. So Sarah, and I don't want to get her last name wrong, Murphy, she's been married for 2 months, so you got to get her married name correct. I'm not going to tell you what her maiden name is because there's enough confusion out there when people are looking for her. But Sarah has been part of the partnership as the program coordinator for the last 2 years. And most of what was done for this conference was facilitated or done by her. So she has been invaluable to the partnership for the last 2 years as she's done everything that's been asked of her. So since she's always done what's been asked of her, we thought, well, why don't you just fill in at the last second for the person who can't make it? And you know what Sarah said? Well, she's sitting up here, so you know she said yes. So we're so grateful for her for being willing to take up any challenge that we need to have done at the partnership.
Thanks, Jim. Yes, so I'm Sarah. Thank you all for joining us for our last session. And to give you guys a break from Jim's jokes, I said I would help moderate this last session. So today's panel is an opportunity to learn more about how movement matters in cancer treatment and survivorship. And I'm joined by 3 wonderful panelists who will share their unique perspectives on the role of exercise in cancer care. We'll start with a short presentation from each of our speakers and move into a moderated discussion before opening it up to the audience for questions. As a reminder, there are note cards on your tables, so if you think of any questions during the presentations, feel free to write your questions on there as we listen to the speakers share their presentations. So our first panelist is Dr. Alex Gunderson, the Director of Cancer Rehabilitation Program at the Brown University Health Cancer Institute. She's the only fellowship-trained cancer rehabilitation specialist in Rhode Island and has expanded the program to 4 sites across the state. Dr. Gunderson earned her medical degree from Penn State College of Medicine and completed her residency in physical medicine and rehabilitation at Harvard's Spaulding Rehabilitation Hospital, followed by a fellowship in cancer rehabilitation at Memorial Sloan Kettering Cancer Center. She specializes in helping patients manage the physical effects of cancer and its treatment, improving function and quality of life from diagnosis through survivorship. Today, Dr. Gunderson will share more about how Brown's Owls Clinic integrates exercise into cancer survivorship care and the powerful impact it can have on a survivor's treatment journey. Dr. Gunderson?
Thank you. It's always interesting to have someone talk about you when you're sitting there. You're just like, yep, that's me. So exercise, and Dan did a great job earlier kind of touching base on this, but this is something that comes up in conversation routinely throughout my clinic day. So again, touching on what Dan talked about, but I talk to patients a lot about what physical activity they're already doing and how we can maximize that and why it's so important to do so. So I talk to patients a lot about what are called metabolic equivalents. It's kind of a way to look at the intensity of the physical activity that a patient is doing. And I don't give them numbers, but I kind of more think about it as sedentary activities like sitting down, lying in a bed, watching television. Light activities, so a slow walk, doing household chores, standing at the sink. More moderate activities, so a nice brisk walk, purposeful exercise, but more kind of the moderate level of exercise. And Dan mentioned earlier, you're able to do the activity and have a conversation, but maybe not quite sing. I also will not sing. And more vigorous activity, where meaning singing or having a conversation would be essentially impossible. So that's more like running, intense biking, a hefty swim, things like that. And I talk to patients about this because I want to give them very clear understanding and guidelines of what kind of exercise we should be doing and how we can get that level of exercise. So there is strong evidence that a higher level of physical activity is linked to a lower risk or likelihood of developing several types of cancer. So some of the ones that we've kind of touched on already, but colorectal, esophageal, bladder, and breast are some of the ones that we have some data on. There's also some evidence that exercising starting from diagnosis through treatment and beyond can help to reduce the side effects of cancer treatment and the cancer itself. And also we know just in general the benefits of exercise. So all of our primary care doctors are always saying, are you exercising? Well, we want to talk about lowering our risk of obesity, adjusting hormone factors, decreasing inflammation, improving our immune function. All of these things we know are very beneficial just in general from exercise. So how I try to get involved, really, like I mentioned, is from time of diagnosis, during treatment, and then through survivorship. So prior to treatment, we call it prehabilitation. It is a word. I'm spreading it as we go. Basically, meeting a patient where they are at time of diagnosis and saying, how can we maximize your functional ability? How can we keep you as mobile and independent starting from now all the way through treatment? During treatment, how do we maintain this function? How do we improve your ability to tolerate your chemo, your radiation, your surgery? How do we combat cancer-related fatigue? And then after treatment, let's recover from everything that you just went through. Let's improve your overall health risk and possible recurrence risk. So like Dan mentioned, there is kind of a number that I like to quote for patients, and I find that to be very helpful because if you just tell a patient, let's just go exercise, you kind of get the stare of, well, how do I do that? So I love to give a number, and again, this is where that kind of metabolic equivalent understanding can be very helpful. So the guidelines quote us around like 150 to 300 minutes of moderate intensity exercise. So again, that's like the brisk walk, stationary bike, things like that, or 75 to 100 minutes of that more vigorous, so like running, more intense biking, swimming in a week. And that can sound very intimidating, but if I kind of phrase it as 5 days a week, do 30 minutes of exercise, that's 150. Phrasing it that way can be very helpful. Maybe you do 15-minute segments. It doesn't matter how you get that number, you just need to hit that number. I also talk about strength training, and I always talk about those like exercise bands that you use in physical therapy, so they're called TheraBands. Light weights, body weight activities to do more strengthening as well, at least 2 days a week. And I always phrase it as, let's start low and slow. Let's pick an easy goal. Like the next time you see me, maybe you can tell me that you walked for 30 minutes a couple days a week, and I'll be your cheerleader, and then we'll move on to the next step to kind of increase that number. And I talk a lot about walking, because one, that's very easy for us to kind of conceptualize. You don't need any equipment, you just need your body. And there's actually a lot of good data that walking is like one of the best forms of exercises that we can do. The other question I get a lot of is like, what can't I do? Is there anything that I should not do because it's dangerous or it could be cause a risk for anything? And really the answer is exercise is safe for patients going through treatment and for survivors. And I get a lot of questions about, well, I have neuropathy, can I still do that? Absolutely. I have lymphedema, or I'm worried about lymphedema, can I exercise? Absolutely. So I do a lot of education on what is safe, and really that exercise is really safe. I also talk a lot about how it can be very helpful to decrease anxiety, improve mood, and decrease pain overall. Also like chemo brain, which I'm sure a lot of people have heard of, is a huge issue. I talk about how exercise can really help with that and kind of clearing our mental barriers and kind of getting a good goal-oriented kind of plan for us. And then the big thing, and Dan talked about this too, how like really aerobic exercise is the only thing that's been data-driven to help improve or combat cancer-related fatigue. So we talk about, like he said, supplements and stimulants and all these other things. None of that really has as much data as exercise does. Another huge thing is improving bone health. So again, the last panel talked about supplements and things like that, but you know, standing-based, weight-based exercise is great for bone health. Like Dan also mentioned that there's like new studies that talk about survival and decreased risks of recurrence. There's new studies coming out all the time, how exercise is really thought and ideally, hopefully, a really big push to improve the survival and also to decrease the risk of recurrence of a lot of these cancers. And I think giving that to patients as this is something that we can do together to try to decrease your risk can be very empowering. And I phrase it as, you know, your oncologist said you need chemo or radiation or immunotherapy. I'm saying that exercise is part of that treatment plan. If we want this to do its job and you to be as comfortable and have the best quality of life going through this, we have to put the time into this as well. So kind of what I do, and Sarah mentioned our ALICE Clinic, which is a great program that we have through Brown University Health. We call it the ALICE Clinic because its actual name is really long. So it stands for Oncology, Wellness, Lifestyle, and Cancer Survivorship Clinic. We are currently mostly based in our Lincoln office. That's where we have the most space. However, we are working to grow to incorporate more of like the Miriam Rhode Island Hospital and ideally also Newport Hospital. But this clinic is like a big multidisciplinary group, which I am involved in more from like the rehab exercise component. We have a primary care provider, an APP, an acupuncturist who's phenomenal. We have a wellness coach who helps a lot with home exercise programs, and she's also a physical therapist by trade. And we have a psychiatrist as well. So we try to help whatever we need to do to help patients engage in their quality of life, and for me, exercise and whatever barriers that's preventing them from doing that, we try to address that as much as possible for these patients. And we have amazing people from the Livestrong program here as well. We utilize their program, and they're going to be speaking a lot more about that. That's an incredible program that helps survivorship patients, and really a lot of my patients rave about it, helping them to have some guidance in terms of their exercise, group-based exercise. That's a huge pull that I think is phenomenal. Like I mentioned, we have a wellness coach, and we try to help patients be able to have gym memberships where they can go to a gym and afford the cost, because obviously cost is a huge issue. And then where I play a role as well as the wellness coach is creating a program that they can do on their own that is feasible, attainable, and also helps them feel a sense of responsibility in their health. Sometimes it's just me having a conversation with them. Sometimes I will print out like an exercise log where I say like, bring this in next time and we're gonna go through it together and I'll give you a gold star if you hit all your marks. Other times we talk about setting an alarm on their phone or a calendar in their house where they say, these are the days that I'm gonna be doing my exercise. Whatever they need, whatever a patient needs, or however I can be helpful, I try to put that together for them. And also I'm a physiatrist or rehab medicine doctor, so I do work a lot with like physical therapists, occupational therapists. If we need more dedicated structure for a specific issue, whether it's lymphedema or knee pain or balance, I help as well try to make sure that we have a plan for that and helping to do referrals as appropriate and as needed for that as well.
Great, thank you. Our next panelists are from Livestrong and YMCA. Jackie Robinson is the director of the Livestrong at the YMCA program at the Hockomock Area YMCA in Foxborough, Massachusetts. With over a decade of experience designing fitness programs for cancer survivors, Jackie has helped hundreds of individuals regain strength, confidence, and community after treatment. She also created the Livestrong Alumni Program, offering ongoing workshops and group fitness opportunities to support long-term survivorship and wellness. A certified personal trainer and group fitness instructor, Jackie is passionate about making exercise accessible and empowering for all. Today, Jackie will share more about the evidence-based Livestrong program and the impact it can have on a survivor's recovery and quality of life. And our final panelist is Judy Amadown, the Livestrong Alumni Network Coordinator for the Hockomock Area YMCA. A breast cancer survivor first diagnosed in 2010, Judy began as a participant in the Livestrong program and quickly became a dedicated volunteer, peer mentor, and later a certified instructor. She helped form the Strong Alumni Group to provide continued support for survivors long after the initial program ends. Judy credits Livestrong with helping her stay active and connected through every stage of her cancer journey. We're excited to learn more about Judy's story and the impact Livestrong has had on her life. Judy and Jackie.
Thank you, Sarah. I'm excited to tell you all about our Livestrong program. And very honored to say that back in 2010, the Hockomock was one of the first YMCAs in the country out of the 10 YMCAs to launch the Livestrong program. And The Livestrong program at the YMCA began in 2007, where we had a partnership with the Livestrong Foundation, founded by Lance Armstrong. Today, our Livestrong program is strictly funded by the local YMCAs. So to tell you a little bit about our Livestrong program, it is an evidence-based program that we offer cancer survivors to regain their health and well-being. The Livestrong program is offered in many ways throughout the country, and our focus is to increase your energy level, your self-confidence. It is to increase your physical ability, your cardiovascular endurance, your balance, your flexibility, your overall muscular strength. So we do this in a program that is set up for 12 weeks. It is a free program, and we meet twice a week for an hour and a half. So during that time, we have a brief check-in with our groups. Our groups are anywhere between, say, 6 and 16 to 17 participants. During that time, the first 15 minutes or so is spent getting to know each other in a typical day. We do some small icebreakers. We keep the mood light. We focus on having a lot of laughs. The next part of the day, or the program, is we make our way over to the gym area, where we'll show you all different kinds of cardio options. Our focus is to get you to do, much like Sarah, 30 minutes a day. You know, that being that some people can get on the equipment and go 30 minutes of cardio, and then we look for ways to challenge them maybe a little more, maybe increase your speed, maybe incline, maybe try a different machine. While others might get on the equipment and maybe do 5 or 10 minutes, and that's okay. We're looking for a safe, slow progression throughout the 12 weeks. After our cardio portion, we make our way over to the strength training machines, where we show you some specific strength training machines. We set you up with a program that works for you. We write out your settings on the strength training machines, the weight that is safe for you to do, you know, the number of reps, the sets, and we'll stay close by making sure that you're comfortable on those machines. If there needs to be any kind of modification, we're happy to show you. After our strength training portion, this is my favorite part, we go into the studio together as a group. We'll show you all different kinds of ways to exercise throughout the 12 weeks. I can't tell you how many times I call a participant to tell them about the Livestrong program, and the first words out of their mouth are, "I don't want to exercise. I can't stand exercising." And I said, "That's okay. Maybe after 12 weeks you might dislike it a little less. You know, come join us, we'll have some fun." So here's where we'll show you how to exercise using your body weight, using towels, using resistance bands, small dumbbells, anything, and that's where we have a lot of fun. After that portion, that might be about 20 minutes or so, we finish up each session with a nice stretch and a relaxation. That is generally everybody's favorite part of the program. So it truly is a magnificent program. We welcome all fitness levels, and we meet every participant at their fitness level. And we do that by at the beginning of the program, we do some functional assessments. So we measure everyone's endurance, their upper body strength, their lower body strength, their balance, their flexibility, and we make a plan from there to make sure that they have a safe journey with us in the program. At the end of the 12 weeks, we do those same assessments again, and it is incredible to see the growth in the 12 weeks. It truly is. So it's just, I can't say enough. I'm very passionate about this program. It is truly life-changing for folks. And if I could read one testimonial, if you don't mind. This, I mean, we have many testimonials, but I'll just read one. This was from a woman, 24 years old. Live Strong at the YMCA was the reason for me to get excited every week. I walked into this program a shell of a person after cancer treatment, and I walked out larger than life. This was a young woman who was on a crew team. After cancer treatment, she couldn't even get out of bed. She couldn't even go do an errand with her mom. She came to the Live Strong program and thrived. By the end of the program, she was rowing 10,000 meters, which was incredible. And we were just so thrilled to have her. But what really stood out for me and having her in the program was cancer doesn't discriminate. She loved everybody in the program. And when I saw her mom, I asked her how she was enjoying the program, how her daughter was enjoying the program. And she said to me, she absolutely loves it. She came home and said, okay, so all my new best friends are over 60 now, which I absolutely loved. So, you know, we truly encourage our Live Strong participants to stay active, stay in touch, because that bond and the friendship will last well beyond those 12 weeks. And that's why we encourage folks to join our Strong program, which I will let Judy tell you all about.
Hi, I'm Judy Immerdown, and I am a survivor of several cancer journeys. All right. The journeys did not come in a straight line. They were up, they were down. After my first diagnosis, going through lumpectomies and radiation, I finished that up, and as I walked out of radiation, they said, "You're all done, we'll see you in 6 months." And it was like, okay, what now? So eventually, 2 or 3 months later, I came across the Live Strong program and said, okay, this sounds good. I have been associated with that program now for a solid 10 years, and I see the program creating results time and time again. Myself, when I went through it, I did it after work, and I met a group of 6 or 7 folks, all different cancers. And at first it was like, what do we have in common? Well, obviously it's the cancer. But this person went through this kind of treatment. This one went through that kind. But you know what? We were all there, okay? And we went through the 12 weeks having some laughs and some giggles and seeing some improvements. And at the end of the program, I found myself crying. I'm like, what now? I bonded with these people just over the cancer diagnosis, which was not on my radar. So as I retired from the business world, I said, I'm coming back to help others do it. So we created in 2015 the Strong program, which is for the alumni. So now when you graduate from Live Strong, you have the opportunity to participate in Strong. This is something that our Hockomock Y instilled. We meet once a week. It's modeled like Live Strong, but it gets you there to the gym, okay? You meet people from other groups, and the hope is that on the other days, you're finding somebody to work out with. And we have found that model works beautifully. People are coming and staying active. We provide some events, which is what I now do. We organize events from a craft card making to we just did an upcycle event using, creating things out of stuff that would have been thrown away. We do a Survivor for Survivor, which is an incredibly fun program, and we bring together 60 people, and we have all different survivor activities, and we work as teams, and it just goes over beautifully. But it keeps them active, and they keep going. They do not just finish the program and then go home and try to, okay, I need to drag myself to the gym. Well, now you've committed and you're coming every Thursday to the gym. At RY, the Strong program is part of their membership, which helps to get them there also. So I think that's it on my part.
Yeah. Lots of activities monthly to keep everyone active.
Yep.
Along with book groups, physical activities, crafts, everything. The point is we just want to keep everybody together.
Yeah.
And I will echo that I have a lot of patients that rave about this, so highly recommend.
Thank you.
Great. Well, thank you all for sharing more about your involvement with exercise and cancer care. To begin the discussion portion, my first question is for you, Dr. Gunderson. I know you mentioned the ALS Clinic has a lot of other healthcare professionals that you work with. How do you collaborate to kind of ensure continuity of care and patients' treatment plan?
Absolutely. So basically the way that patients can get into the survivorship clinic is their oncologist refers them to our clinic. They then get established with Dr. Christine Duffy, who's the head of the survivorship clinic. And she's kind of the gateway to figuring out what that patient specifically needs, whether it is, integration with our wellness coach or maybe instructions on how to get to the Livestrong program, whether it's something specific that I can help with, whether it's joint pain or neuropathy or balance or whatever I can help with, or maybe if it's something totally separate, like they need a pulmonologist because they had pneumonitis when they had immunotherapy, and that's the really big barrier, or they have a lot of, their depression or anxiety has not been adequately treated and they need to get set up with our psychiatrist. So she's kind of the gate stop and helps to kind of make sure that all these patients get where they're supposed to be. She then has a very diligent kind of, not a spreadsheet, but these epic lists with all of the patients and whether they're new or follow-ups. And we have monthly meetings where we meet as a huge team, including providers that actually aren't in the survivorship clinic but are involved. So we have a monthly meeting where I call it the meeting of the minds because I just feel like this is like the smartest people are all in one room together. But we have like a cardiologist, a pulmonologist, a GI doctor, a rheumatologist, a psychiatrist, me, just name any kind of IST provider you can think of. They're on this meeting. And we talk about every patient. How can we help? Who needs a referral? Maybe we're trying to avoid referring to the pulmonology, but can we get something started, or what would you suggest? And I find this great because patients are getting this like world-renowned, very head-to-toe care by seeing one provider to start with, and then we take care of the rest. And I think patients find it very helpful that we're addressing each piece that needs to be addressed to help them take that next step forward and really have that quality of life that maybe during their treatment kind of was pushed to the wayside and kind of got all chaotic because of the treatment that they had. And then again, we do divide out and refer out as needed or make sure they get hooked up with like things like the Livestrong program. So it's a great program. I think, again, we're hoping to expand it even more to touch more patients' lives. But so far it's been very well received, and I do think it's a great opportunity to really check all the boxes and make sure that we're addressing everything that a patient might need.
Great, thank you for sharing. Jackie, I know we've heard a lot today about, I think, one of the main concerns and side effects like neuropathy. How does Livestrong adapt activities for survivors that might be dealing with side effects like neuropathy in their exercise programs?
Sure. So, like I mentioned, we do some pre-assessments, and we measure their flexibility, their balance, as far as if they have neuropathy in their feet, overall body strength, and we set up safe accommodations for them. So, for example, if a participant has bad neuropathy in their feet, when they are in the studio or in our program, we make sure they have a chair, maybe to lean on for balance, or if they need to sit, they're near a wall. We also have a lot of eyes on our participants. We have what we call mentors that go through the program, and they come back to volunteer. So there are an extra set of eyes and ears that are always around our participants as well. So those are certain safety precautions we take for folks who have neuropathy or maybe any other balance issues that may come up.
Thank you. Judy, as a survivor and as someone who's gone through the program, beyond the physical benefits, did you notice any changes in your confidence or outlook in life? And could you share a little bit more about that?
Oh, 100%. In myself, I never noticed it when I finished the program, but my husband looked at me one day and he says, "You're happier all of a sudden." And I'm like, oh, okay. So going from that, we see it all the time with our participants. They just grow in confidence. The idea that all of the treatments have made you deconditioned, and then the fear of, what next? What is going on in your head, and how am I going to survive this? The program just organically takes care of that. It is incredible the support that everybody receives from the person next to them. They're all different cancers, but somehow that bond is just amazing. So people are there for them, and it makes 100% difference in their attitude. And we celebrate everything. That's part of the program.
We do.
We make, they walk into the Y, and for once, you're not at a doctor's appointment. You're doing something for yourself. So that alone helps you. And then they go through, exercise with Jackie. That helps a lot too. But in the end, it's celebrating someone's birthday. It's celebrating Halloween. Halloween is a very big one. Mardi Gras. And then we have the holidays. So you name it, we can celebrate it.
Yeah.
But that's part of healing and feeling more relaxed and confident.
Great, thank you. Dr. Gunderson, what are some barriers patients might face when trying to engage in physical activity, and how do you kind of help them overcome those challenges?
Definitely a lot of barriers. I think one of the big things, especially if a patient is currently going through treatment, and I'm either suggest maybe they do have some balance issues, and I'm like, I think physical therapy would be helpful, or I start talking to them about exercise, and they're like, well, I have radiation every day, or I have chemo every 3 weeks, and then the week after chemo, I feel miserable. That's a huge mental and physical barrier. So what I do kind of focus a lot on, and actually kind of piggybacking off what one of the dietitians mentioned, is focusing on what can we do. I know there are some things that we can't do, and maybe we can't get to the gym every day, or we can't get those 30 minutes every day, but maybe on the off week when you're not taking your chemo pill, or the 2 weeks in between treatments where you feel a little better, let's maximize those days. Let's maximize those weeks. Let's get that, whatever we can get in, whether it's 10 minutes, 5 minutes, 30 minutes, an hour, let's maximize those days. And again, a lot of times I will print out exercises, handouts, exercise calendars for them, whatever we can do to make it more feasible and kind of almost like a part of their treatment. Other big barriers are fatigue. Again, if you tell someone who has fatigue, hey, we gotta exercise, you get the kind of, are you kidding me? So a lot of it is like education, again, starting low and slow. How can we just start thinking more about exercise or working more towards that, and how much guidance do they need? As a physiatrist, I have a lot of patients with arthritis, with neuropathy, whether it's from chemo or treatment or not from chemo. So I try my best to address whatever that maybe more physical barrier is. So I do joint injections, I'll use medications, I'll use topicals, I'll use stretches, modalities, whatever we need to do. So usually the first thing I work on with them is, if I say the word exercise, what's the first thing you think of that makes you not want to do that? Is it pain? Is it fatigue? Is it anxiety? Is it stress? Is it whatever it is? And then I try to like piece them all apart and address them as best I can, so that way we can like take that next step. And this doesn't happen in one session. I'm not magic, I wish. This takes time. And so a lot of times, like, I'll see a patient, I'll spend an hour with them, and then I'll say, hey, I'm gonna call you in 2 weeks, and I'll put a reminder, I'm gonna call you and you're gonna tell me. Or I'm gonna see, you're getting treatment, I'm gonna come down to treatment next time and I'm gonna check in and see how you're doing. So it does take time, but I think piecing apart what the barriers are and then trying to address each of them individually does help to make it a little less daunting and overwhelming.
That's great. Nice. Jackie or Judy, kind of a similar question. What are some of like the most common challenges or even barriers, like transportation or awareness, does the Y and Livestrong deal with, and how do you kind of overcome those barriers for patients that are looking to get involved?
So similar to Dr. Gunderson, we have the same barriers as far as physical, psychological, definitely fatigue, lingering side effects of treatment, no confidence, worried about getting injured, not sure how far to push their body, where to begin with exercise. Part of the agreement I have with a lot of folks in the group is just show up. Just get here. And, like I said, we start every session with a check-in for about 15 minutes, and promise me, just show up. If you don't feel good and you are tired and, you're having effects from treatment, if you just walk through the door, I'm happy. I just want you to set, a habit. I want you to form a habit. I can't tell you how many times someone has walked through that door and said, I'm here, I'm tired, I wanted to stay in bed, but you promised me if I show up, I can go home after the talk. And I said, sure. And I did. And I won't go back on that promise because I'm thrilled you showed up. That is the most important piece. And 99% of the time, they stay. They stay bit by bit. They'll say, okay, I'm just gonna go out and I'm gonna walk the track for 5 minutes and then I'm going home. Okay. Chances are they're there the entire time. Yeah. And, little by little, that's all. As far as transportation, yes, that can be a barrier. We try to set our schedule for the Livestrong program. We offer our program in January, April, and September. People can plan far ahead, make arrangements. We have an in-house social worker who can also help with any transportation issues and make some recommendations for us.
We also have, RY includes a 12-week free family membership when they enroll in Livestrong. So therefore, there's the avenue for family to bring them and they can hang out. Occasionally, some of the family will join one of the groups just as an observer. And that helps with a lot of, the anxiety of being part of the group.
I also just want to echo that, people are have that, either the confidence or I'm afraid I'm gonna do more damage. Or I was like, I'd rather you ask me a question. Like, there are no silly questions. Ask me a question.
Yeah.
If I don't know the answer, I'll figure it out. Hopefully I know the answer and I try to know the answer. But I'd rather someone ask me, even if they're like, this sounds so silly, but can I do X, Y, Z? And I'm usually like, absolutely. Or if it's something that I'm like, that sounds a little high impact for right now, why don't we modify it? But I'd rather the question get asked than it festers and then it becomes a big barrier. So I'm like, let's get the question out there, like message me in the portal, call my office, I will call you back, we'll figure it out. So I'm always like, there's just ask it. I'd rather you ask and not worry, and usually that is also helpful.
Yeah, absolutely.
Thank you all.
Can I, oh, sorry, didn't mean to. One other thing that kind of eases the anxiety of getting back into exercises. I generally meet with everybody in the Livestrong program before we start, and we go over any questions, any issues you may have. And sometimes just showing them, here's the room we meet in. Let's take a walk through the fitness area. Here's where we're going to spend the first 20 minutes. And here's the machines and some of the machines that we're going to walk you through and show you. So a lot of times that eases their anxiety as well with the exercise.
And we use our mentors as that extra set of eyes. But if someone is hesitant to be on a machine, the idea that one of those mentors just walks up and is talking to them while they're exercising. And lo and behold, their 10 minutes that they were going to do, oh, it's now been 15 minutes. So it's a win-win. So we do use the mentors to sort of help.
Crucial, yeah.
Kind of a question for everyone, but looking ahead at your specific programs, what are some of your hopes for your program's growth and impact on cancer survivorship and the cancer community in Rhode Island or in the area?
I would say, so I'm a one-woman show, which is fun, but also terrifying and overwhelming. I would love for any patient that got diagnosed with any subtype of cancer, whether it's thyroid, head and neck, breast, prostate, to meet someone to educate them on exercise and nutrition and all these things, like as soon as they get diagnosed, and then like track them and stay with them and modify and adjust and monitor as they go. That's the dream. Obviously, I cannot do that in the state of Rhode Island, but I do think there's such a role for educating up front, having that knowledge up front, having that support throughout all of it, knowing that there are things like the Livestrong waiting, as an option. So I would love to just be able to touch all these lives and help in any way, shape, or form. So I think that's like the dream. And a standalone rehab, but that's a whole other, that's like the 20-year plan.
Good plan.
That's a good plan.
So similar to Dr. Gunderson, I would love to continue growing the program, spreading awareness, partnering with medical providers. It's just so important to get the word out that, to anyone who's had a cancer diagnosis, it could have been yesterday or 30 years ago, that there's a program we offer that's free, that can provide so much hope, so much confidence, rebuilding. It's magical. And the family, the bonds, the camaraderie that is going to come out of that program is going to last a lifetime. So I would just love for everyone to know about Livestrong. Spread the word.
Yeah. And from an alumni point of view, I would love to just see people constantly coming, that there's no end date.
Right.
And they come and enjoy, and most importantly, exercise. And I wish we could have, every one of them return, and we're there for them.
I think the big thing is access. So I would love to just have more patient access to all of these things. Like when Dan was talking about what the Zakim Center has, I was like, oh my gosh, can we have one of those here? That'd be great. So I think having that's the dream, right? The Livestrong program's on floor 2, and the PTs are on floor 3, right. and the OTs. Then I'm up, and then that's like the real, that's the real dream.
Absolutely.
But I think like getting the word out there that there are programs that we have, and these are the locations, and these are where the providers are, and how we can be helpful, and even the ZACM Center having things online that we can provide to people, I think that's great. So I think increasing access would be huge.
So to kind of follow up on that, for individuals who might not be patients at Brown, might be out of state and don't have access to OWLS, do you have any suggestions for resources or organizations that they can look into to kind of find like comparable resources?
Yeah, so, I mean, he brought up like their online is great. Sloan Kettering has so much on their websites. I always direct patients there. I am in the process of making exercise videos. I should have asked you guys, you could have been in them with me. So we have online resources for patients. They are not online yet, don't worry, you'll all be the first to know. But I think the Dana-Farber and Sloan Kettering have a lot of great options, at least like for us to start. I am embedded in the Brown University Health, but I do have a half day of clinic where I am able to see patients that are not affiliated with Brown University. So if they're at South County or out of state, that is an option as well. So I am trying to grow that in general.
And similar question, Jackie or Judy, for individuals who might not live near your Y, what are some best ways for them to find a Livestrong program in their communities?
I would recommend going on the Livestrong website, livestrong.com, putting in your zip code and finding a YMCA close to you. You know, the Livestrong is offered around the nation. There's a lot of YMCAs that do facilitate the program. So it's as easy as just going on the Livestrong site and putting in your zip code.
And one more question before we open it up to the audience. Judy, what advice would you give to other survivors who might be hesitant to join Livestrong?
Oh, just join. Make that call. Send that email. And I would be shocked if you regretted it. There's no regret. You will get a lot out of it, 100%.
Yeah.
Well, if anyone else has any questions, there's microphones or note cards. Open it up to the group.
I was just wondering if there's any health condition that would rule you out of participating in the Livestrong program, like spinal stenosis, for example.
What was the question? Could you repeat that?
Is there any health condition that would rule you out as ineligible for the Livestrong program? For example, if you have spinal stenosis, would that be an exclusionary criterion?
I believe in order for you to participate in the Livestrong program, you had to have had a diagnosis of cancer. If there's other health issues, we'll work with the other issues. Absolutely.
Thank you.
You're welcome.
I have had a couple of patients like bring a form in if there's like a question. I don't know if it's specifically for you guys, but usually I don't think I've ever said that somebody could not.
Yeah, usually, you know, we'll work. I mean, we've had people come in, you know, wheelchairs, walkers, chemo pumps, diabetics, you know. We're very comfortable working with everybody. Absolutely.
Megan has a question.
Hello, I'm a lot shorter. Thank you all. I appreciate you being here to present today. And forgive me if you touched on this and I missed it, but we know there's other Ys in the state, but they don't all have Livestrong. So do they need to create that program themselves, or should residents approach them and say, we want to have this here too? Any recommendations on how to get Livestrong everywhere?
I think that the Livestrong program is funded individually through their Y, so it would be something that the Y would have to develop. And I think as far as in the state of Rhode Island, it has been growing. I've noticed quite a few more YMCAs in the state of Rhode Island coming in and developing the Livestrong program, so it's getting bigger and bigger.
Could you just explain the process? Like, do you have to be referred by your oncologist, or can you just, if you know of the program, somehow you can just come or apply? And also, after you go through the 12-week free program, then do you subsequently become a Y member to continue on with the other program?
So, great questions. Anyone who has a cancer diagnosis can call the Y and inquire about the Livestrong program. And if that were the case, you would call, I would take your phone call, I would connect with you, send you some paperwork, and one of those forms would be a medical release to bring to your healthcare provider. Another form would be an intake form that would have some general health questions on there for us to get to know you a little better. And then the third form would be a membership form where you and all the family members in your household would receive a free membership to the Y for those 12 weeks you're attending the Livestrong program. So that's one way to get into the program. The other way is you could ask your healthcare provider to make a referral to the Livestrong program. If you knew of which program you wanted to go to, your healthcare provider could certainly make a referral as well. So when you're done and you've completed the Livestrong program after the 12 weeks, we do encourage you to continue exercising because it is hugely important in healing and recovery. So we do offer a 50% discount to the YMCA for the following year if you want to continue. And the Strong program, which would be the alumni program, would be free if you're a Y member. If not, there's a small cost, I believe, for the 12 weeks of $75. We never want finances to be a barrier for you to exercise and be a member of the Y. So even if that 50% discount does not work in your budget, we'll find a way. We have a scholarship program, a place for all, and we will find a way to get you in the YMCA if you wanted to continue after the Livestrong program.
Hey there. Kudos to this panel because I'm a huge champion of both the Y and everything cancer survivorship. My question is a little bit of a loaded one, and I apologize in advance for that. Those of you who know me, I do comprehensive cancer control for the state. So in this crazy time that we're in, where we all know that, especially in Rhode Island, reimbursement rates are very low for providers, and that seems to be limiting our number of providers of all types. Also, the model historically has been that hospital systems set up survivorship services just for their own patients, and they don't open them up to other patients. And I get that because there's a lot of competition, et cetera. But from a different perspective, I'm wondering what could be done to set up collaborative and sort of organizational relationships so that survivorship services could be available across treatment facilities and integrated really well so that not everybody has to have every type of specialty care available. I'm just wondering if you have any thoughts about that. I, of course, am a dreamer, so.
I think it's a great question. And just to echo, like as a provider, it's probably equally as frustrating not being able to expand what we want to expand to. I know that like from the survivorship, the Owls Clinic, like there has been a lot of talk about like how we can open that up. If that would be the case, we probably have to find like more space, because obviously, right, we're currently like in like the infusion center, and that's where like the barrier comes in to like, we don't physically have the space to take on more patients. It's interesting, like as in general, like Brown University Health is growing, as like, you know, a lot of the Boston groups like Dana-Farber, how they're spreading around Massachusetts and Rhode Island, et cetera, is like, we're now working so close together, why can't we figure something out? Like we're both in Foxborough, let's work together. So I know that that is something that has come up a lot in like a lot of our conversations. I don't know if there is a quick fix to let that happen. I think, like you said, physician or provider access is tough and space is hard. And then also sharing all of our data, which I wish we just had one system for everybody so we could just see everybody. So I hear you. I don't know if there's like an easy fix for that, but I know that like, at least from the Owls Clinic, that has been a conversation about how we can try to like reach out to more patients that aren't just our own system. You guys don't have that problem.
No.
Livestron doesn't have that problem.
I don't have that problem. Thank you.
So thank you, Sarah and panel. Great presentation. A lot of work goes into planning this summit every year. We start in January, and the committee works through each month, once or twice meetings a month. So I want to take a moment and thank them and let you thank them for the work that's gone on. So the planning committee, first of all, is Regina Donald. Regina's standing up in the back. Megan Daniel and Sarah Murphy, who you've seen up here. Chiaco Catherine, stand for Chiaco. Thank you. Maria Gemma, Norma Hardy. Okay. Good. It's a humble group. Nobody stands, they just wave. That's good. Nancy LeBron couldn't be here. Diane Martins. Okay. I mentioned Sarah already. C. Kelly Smith. Pat Stout. So it's the planning committee. And then we have a group of people who come every year and volunteer. Many of them get here at 6 a.m. to make sure everything's set up and ready to roll and can run smoothly. So we want to thank them. A lot of them are out in the hallway right now, and they're instructed to tackle you if you don't get your name tag off and put it in the box. So please avoid injury and put your name tag off and put it in the box. But we want to thank them, and I'll just briefly mention their names. Lynn Basilio, Elena Blanchette, and her son Matthew. Mary Jane Corvase, I know she's out in the hall. Sherry Daniel, Linda and Joe Beck, or maybe I'll say Joe and Linda Beck, but they're both in the back. Tandra Falou, Lou Letta, Jeanette Nissette, Benata Philvalle, Mike Ratty sitting at the desk coordinating our film, and Ida Roca, and Susan Yarborough. So I want to thank all of them for all the time that they put in. Now, if you've enjoyed this, I invite you to join the partnership. Now, that's not too hard to do. It's a little bit beyond me, but you know, I asked my nieces and nephews. So all you have to do is click on the QR code in the back of your brochure. It will take you to the partnership's webpage, and you can join the partnership with that. Also, you will be getting mailed, or you can do this faster by just looking at your brochure and clicking on the QR code for the evaluation. It truly helps the partnership to do if you do the evaluation, because that's where we get our ideas for the next session. So last year, it was suggested that we talk about some of the other interdisciplinary team and their skills and what they do to promote cancer. Thus, we had a session on nutrition and exercise. So just if you think it doesn't apply, please do that for us. It really helps. So the resource list for the Cancer Summit, you can find all of the resources. This is the show and tell part of it. You can find all of the resources there by scanning the QR code. So you've heard Dan speak about what the Farber has, and you've heard the other panelists talk about different resources that are available. So we want to make sure you get those. And again, remember, if you missed any part or would like to see another part again, it will be on our webpage. So just to be aware of that. So thank you very much and have a wonderful afternoon.